And so welcome to the first day of this third annual Global Conference on Parenting Interventions. And the purpose of this conference is to bring together the global research of parenting interventions and share experiences, successes, challenges, and barriers to implementation. The speakers in this conference have a fascinating breadth of experience. I believe we will learn much from their extensive work. We come together as people who are passionate about the healthy development of children. Each of the 2 days of this conference will be 3 hours with a brief break partway through. My name is Andrew Reeser McDowell, and I'm from Canada. This conference will be recorded so you can review parts of this possibly in staff training in your organization. We will send the link in the coming weeks. And we ask you to please mute yourself when you are not speaking. So this global conference on parenting interventions is sponsored by 10 different organizations, and we're delighted that they're able to sponsor this one. You can see them: Pakistan Institute for Learning and Living, Zayuddin University, University of Toronto, University of California at Davis, Center for Addictions and Mental Health in Toronto, Manchester Global Foundation, University of Manchester, Central African Institute for Living and Learning, Global Mental Health and Cultural Psychiatry Research Group, and Mercy Care NHS Foundation Trust. And we thank these groups, these collaborators, to support as they're supporting this conference. During the presentations, if you have a comment or question, please put it in the chat box. The presenter can either speak to it during or after the presentation if there's time, or get back to you later. Thank you to the Conference Planning Committee, and a special Rabia, Dr. Naseem Chaudhry and Dr. Nusrat Hussain. Rabia Fahad has been the primary organizer of this conference and has done an outstanding job. And when this conference is finished, she'll get some sleep, because I know from her when she's been sending emails that she's been up very, very late at night. So Rabia, get sleep when you're finished, but not during the conference. Don't go to sleep then. Professor Naseem Chaudhry is joint chair of this conference. She's CEO of Pakistan Institute of Living and Learning, Associate Director, Global Mental Health and Cultural Psychiatry, Professor of Psychiatry, Dow University of Health Services, Head of Psychological Medicine, Remedial Center Hospital. And Professor Nusrat Hussain is also joint chair of this conference. He is Professor of Psychiatry, Director of Research Global Mental Health, Division of Psychology and Mental Health, University of Manchester, Director, Research and Innovation, Global Center for Research on Mental Health Inequalities, Mercy Care NHS Foundation Trust. Our first speaker today is Jill Thompson, who is a professor of perinatal health within Maternal and Infant Nutrition and Nurture Unit in the University of Central Lancashire. Jill is a psychology academic, has a psychology academic background and a PhD in midwifery. She has led or been involved in a number of research, evaluation-based projects funded by the Department of Health, National Institute of Health Research, Health Technology Assessment, and third sector organizations. Jill's research interests relate to psychosocial influences and implications of perinatal care, with interests in birth trauma, factors that impact upon maternal well-being, and peer support models of care. She also has a particular specialism in a range of qualitative methodologies, in particular hermeneutic, phenomenology, and qualitative narrative-based systematic reviews. Jill, we're delighted to have you as part of this conference, and you go ahead.
Thank you. Yeah, is that good? Just put it.
Yes.
Great. Okay, thank you. Thanks so much, Andrew. So yeah, I'm going to talk to you today about something, an area of work we're currently involved in, about postnatal listening services following a traumatic birth. So this presentation is based on, we've been doing a big systematic review. So we found 27 articles relating to this subject area. We've also done consultations with people who provide these postnatal listening services and parents who've received them. So in this presentation, I'm going to give you, because I think this is quite, we did a bit of a mapping work about who provides these type of services. So I'm aware that some might not be aware of them. So I was going to give a little bit of a history, talk about the current state of the listening services in the UK from the most recent survey data we have, some of the evidence of interventions in this area, midwives, service user experiences, issues to think about timing and location when we provide this type of care, and about the work we are continuing on to do next. So just as like a little bit of a history, so Alfonso, 1977, he was one of the first to kind of highlight and recognise that women have these missing pieces from their memories following a difficult or traumatic birth. And this desire to work with others and maternity professionals to help them reconstruct their birth narratives. And in the UK in the 1990s, these kind of postnatal listening debriefing services started to be rolled out across the UK. So with this intention to kind of reduce morbidity, to kind of improve, obviously, mental health for parents, but also as a risk management tool, thinking actually if they intervene, talk to people about the complaints about the care, about the traumatic experience, it would stop the number of complaints. And these services generally involve women meeting with a maternity professional, often a midwife, to review what's happened to them and to ask questions. So it's kind of changed for us in the UK. So in 1999, the Department of Health actively promoted postnatal debriefing. However, there was then a Cochrane review that looked at the evidence of seven intervention trials and found no evidence. So this changed our guidance. So in 2004, our postnatal guidelines say don't be doing debriefing services. But, however, despite this lack of guidance, maternity trusts continue to offer these type of services because it's in line with what women want and what women need. So when we look at the evidence about what women want, sorry, I have to keep moving people's pictures so I can get the text. So what women want, they want an opportunity to understand what happened to them and why it happened to them, to fill in these gaps in their memories. Also to get this sense of validation, some acknowledgement that this is a real version of events that happened to them, and particularly for women who've had what appears to be on paper a straightforward birth. And certainly, you know, from my PhD, women had had a reasonably short vaginal birth was one of the worst traumatic experiences they could have imagined. Women want an opportunity to release this self-blame through knowing that there was nothing they could have done to have made a difference during the birth. Information on birth trauma to help them understand about the trauma-related symptoms they've been experiencing and about what support's available. So the most recent kind of survey, well, I did it in 2019, looking at these kind of services across the UK. So we managed to get survey responses from about 35% of maternity units in England. And what we found that there's around half of them have no funding. So they're providing the services in their own time, again, in this recognition of what women want, but they're not commissioned. So just under 60% of services are provided solely by midwives, but the others are more multidisciplinary. So most of them give this opportunity, as I was saying before, to just talk about the birth, how they were feeling, explore care decisions. But some of them also go a bit further. So they'll talk about future responses, how women are going to feel going forward and when they're pregnant again, helping them to normalise what's happened to them. And just, approximately 55% actually discuss birth trauma and trauma symptoms with the women. We found about 50% aren't routinely offered. And this is often because they don't want to open these floodgates and get overwhelmed with referrals, particularly when there's no funding. So this tended to be on a more discreet basis where midwives or health visitors would refer women in who they felt would benefit from this type of service. I think an area that was kind of particularly interesting is about the kind of generally lack of training. So about 40% of the services had no specific training for the staff who were delivering it. And even those who did, it was widely variable. Some had like an MSc in counselling, Some had done 2 days in birth trauma. There's kind of a lack of data recording. So when you're asking about women accessing the service, you'd get very vague responses because it wasn't formally recorded. And again, back to commissioning. And only 25% of services have been built on any evidence or theory. So when we look at the intervention-based studies being done in this area, so there's been 15 trials to date, 3 in the UK, and 1 was pragmatic. So really they were just looking at the effectiveness of what was already in operation. So most of these trials were delivered in a very early postnatal period, and I'll talk about some of the problems with that in a minute. Different dosages, some had 1 session, some had 2, different measures being used. Some just measured depression, some trauma, PTSD, some did both. Also, they were targeted to different individuals. So some of the trials were targeting women who'd had a very complex birth or an emergency cesarean. Some were offering to all women, or some were just targeted to those who had trauma-related symptoms. There was different or lack of information on what training had been provided to deliver these trials. There could be a lack of intervention details and varying results. But overall, when you kind of look at the evidence more in depth, interventions that are targeted to women who have trauma symptoms and the staff members have had some form of counselling training tend to be those who are more effective. And we also found generally there was a lack of quality research. So, it's really important to have both. So we've got the trial evidence, does it work? And a qualitative evidence to find out why it works and for whom, etc. But there is, a generally lack of qualitative research supporting trials. So the most well-developed intervention has been the one by Jenny Gamble and colleagues from Australia. So these were the elements, and she based this again on reviews and talking to professionals and talking to parents, and it came up with this model where it was about developing a therapeutic relationship, working with the women's own perceptions, so very this subjective-led account of what happened to them. So supporting them to express their feelings, filling in missing pieces, helping them to connect how they were feeling with how they were behaving, so to make those links with the trauma-related responses. So obviously reviewing what happened to them, helping them to think about social support available to them. So not only what they had within their own families and support networks, but what was available locally, helping women to reinforce positive approaches to coping and exploring solutions. So the intervention ran that they trained midwives, and then there was two points of appointments. So they saw women within 72 hours within a delivery suite, and then recontacted them 4 to 6 weeks later by telephone. Effectiveness wasn't too clear, to be honest, within this original trial. So they found that it did reduce trauma symptoms, but only at 3 months. So they looked at it at baseline 6 weeks and 3 months. So they only found it at this later period. They found there was no difference in the numbers of women meeting the criteria for PTSD in the interventional control group either. But this model has been replicated in Iran, and they did find significant reductions in PTSD and other measures. So they did show evidence of effectiveness. So in terms of who best to provide, well, we've done some work in this area as well about who best to provide this debriefing service. And the overwhelming is that they want it to be a midwife, was most preferred. And less than half wanted it to go to specialist services because of the stigma associated with more official mental health services. They felt that midwives could help explain things, give these unresolved questions, and to kind of help them, saying before, work out this narrative to link this sequence of events and help them process this memory. And kind of mixed reaction about who the midwife should be. It was one of the studies undertaken in Iceland, and it was around half feeling that they wanted to speak to the midwife who delivered their care, whereas others didn't. And I think this really depended on the relationships they had with the midwives during that intrapartum period. So in terms of midwives' experiences of delivering these type of services, they'd talk about it being a new skill and actually moving them from being someone that wanted to solve problems to really valuing this opportunity to working with women to find their own solutions. They valued the fact that it made them more empathic and understanding, and also not making assumptions about what constitutes trauma, this kind of recognition of how subjective it was. They'd be expecting a horror story, or when they read the notes, they had expectations about what women would find to be traumatic, but actually this wasn't the case. And they valued the fact that it gave them this personal and professional development. So as this quote here, people feeling that they were giving back and the midwifery has value and meaning again. From a more negative perspective, some felt that actually just really out of their comfort zone delivering this type of intervention. There was in one of the trials that midwives were really reticent about providing this service to teenagers because they didn't want to encourage them to have more children. Some felt incapable. They were very worried about what would come up and how they would respond. There was this sense of defensiveness, particularly if they were hearing criticisms about, midwifery care. And some highlighted that they needed further training. And actually, through our work that we've been doing when we did the consultations, this were the kind of training issues that came up when we were talking to those delivering the service. So issues about counselling and CBT, interpersonal skills, so wanting more skill development in active listening, body language, how to develop that shared language with parents, how to be non-judgmental, validating, asking open questions, keeping conversations on track. Again, about this issue about defensiveness, how to support complaints. People are often really fearful about this, saying the wrong thing, then all of a sudden the woman was going to make a complaint. How to identify issues for onward referral, so picking up those mental health issues and cues to make sure they get appropriate support, and psychological safety for all. So when asking about service user experiences, you find parents that really valued this space to talk, having this opportunity to fill in the gaps, and having this opportunity for reflection gave them this real sense of feeling cared for. So there's a nice quote here saying it was a bit like counselling without feeling you're being interrogated or psychoanalyzed. And they felt this kind of in-depth conversation being dealt with non-judgmental and listened to without sympathy, felt women were really able to open up and express how they were feeling. There can be lots of fears about women talking about these issues because of how they're going to be judged. But actually being in this safe, supporting, conversation, felt that they could more freely disclose what was happening to them. And a number of women also talked about how they could move on with the healing, and particularly talking about or thinking about going on to have a further child. So actually how that listening, debriefing intervention really moved them from this space of never being able to go through it again to actually being a possibility in the future. Not all reviews were positive. And I think we found this as well, and within our consultations, as well as within the published literature, feeling it could be a tick box exercise, that actually they weren't being listened to, and that the professionals would just recount and read the notes to them rather than listening to their experience. They felt they went away with having questions that were answered, so things being unresolved. It could be nice, but actually not very helpful. And some feeling actually they wish they'd had more than one meeting, so up to 20% across the studies, because they felt, not everything was addressed in that one meeting. There's also issues about women feeling that they not only blame themselves, but when they went in to have these conversations, feeling even more blamed because of how defensive the professionals were. So it's quite a long quote here. This is from a study in Australia by Holly Pridis. So the woman saying she gave him a piece of paper to the doctor with her questions and said, I want you to read this. The things I'm upset about. You didn't acknowledge my fears. And all the doctor said at the end was, I don't know what you want me to do about it. You weren't the only one that was panicking. Some women feeling that actually after going to the meeting, it aggravated and created more problems for them. They actually suffered more with mental health issues following the session. And from the study by Priest, found 33% found it was minimally or not at all helpful. So there are issues about when to intervene, because when you look at the trials, they're intervening in this really early postnatal period, 48 to 72 hours after the birth. But actually, when you look at the PTSD and the wider literature, this is quite problematic. They're thinking it takes at least 3 weeks to help develop and integrate these memories, particularly with something difficult, and overwhelming, and particularly when they've got a new baby, and actually intervening without insufficient emotional distance could actually prolong the distress by creating catastrophic memories. You're making it worse, and it can interfere with this natural coping process. So thinking that there has to be a space between the birth and when you have these conversations to allow this to happen. And actually, with some of the papers we included in the review were just evaluations of local services. And the time in which women were accessing this support could vary widely. Some were going in at 4 weeks after the birth. There was one 45 years, another one 6 to 7 years. Sometimes this was relating that they didn't know this service was available to them. So really going back to what I highlighted before, some of these services aren't promoted. But for some of them, it took a long time. That the average seems to be around 4 months to 12 months. But certainly going back to my PhD, it was often only when women got pregnant again that they would then seek out this help with their previous birth. And yeah, this kind of really highlighting what the NICE guidance does in the UK, that having this flexibility of wait and watch approach rather than jumping in and intervening too early and causing more problems. Issues about where to do this. Actually going back into a hospital setting can be really re-traumatizing for women. However, if they are pregnant again, going back in again, revisiting the scene of their trauma and this difficult birth can be really healing. And what's come out from within the literature and our consultations, it's really important to give women choice as to where these conversations happen. It could be in a hospital, but away from delivery ward, home, community, telephone. And actually now, as I know, we're working with mental health services who are delivering sessions and treatment online, and that's working really well. But really working with their preferences, so you don't cause more harm because of where their location is. And it's really about seeing these listening services as a step wedge approach. It's to help start facilitating the processes. And for some women, that might be enough. They had unanswered questions, there was bits that were really bothering them, but actually being able to go through, review the notes, ask the questions, be heard is sufficient. But actually for others, it's recognizing that there needs to be that follow-on process in place. So as Farland talks about here, contact soon after to get a bridge for later screening and treatment if required. So yeah, just in terms of what's next for us. So we see this as a really important part of the recovery process, and this, what we know in the evidence and talking to people just reaffirms that need. So we've been working with academics, clinicians, parents, service user representative. We've co-produced a training program for staff. We've developed a care pathway. We've created lots of documentation to go alongside this, information leaflets, getting the advertisement right. So we're just looking to kind of implement this within one maternity trust, and then to do an in-depth evaluation, looking at how it affects recovery, how it impacts on trauma symptoms, what components work best, and then to start rolling this out across the wider footprint. Yeah, and planning for further effectiveness studies. Okay, that's it. Thank you.
Well, Jill, thank you very much for this very informative presentation. We certainly wish you well. What impressed me here on this one is that you're dealing with, you think we wish it would be black and white to be all good or not so good. I mean, you're dealing with really shades of gray here and finding your way through these things, and you got to be really determined. And I wish you well, Jill, and we look forward to hearing updates as time goes by.
Thank you, Andrew.
Thank you. Naseem will introduce our next speaker. Naseem.
Thank you, Andrew. So it's with great pleasure to introduce Dr. Sumbul Sohail. Dr. Sumbul Sohail, she's a professor of Obs and Gynae, very nicely following from Jill's talk, at Ziauddin University Hospital. This is in Pakistan, Karachi. And this is where our research center for parental mental health and child well-being is also placed. So collaboration of University of Manchester, Ziauddin, and our organization, Pakistan Institute of Living and Learning. Dr. Sumbul is an executive member of the research wing for OBS and Gynae. She's responsible for training programs for postgrads, fellowship, and MS. She is also the General Secretary, Pakistan Menopause Society, Chairperson of Research and Publications at the South Asian Federation of Menopause. She has a number of national and international publications. Welcome, Dr. Sumbul. Rabia, has Dr. Sumbul joined?
Yes, she did join. Maybe she's mute. Dr. Sumbul, can you hear us?
Out.
If not, is Marie Yap available? Maybe we could do that. We could just reverse them a little bit.
I think Brandy probably is Dr. Brandy Walk.
Is Brandy available? I saw her name here. Okay. Brandy, are you available that you could, we could do a bit of switching around here?
Yes, that's fine.
Okay, good. Thank you. Okay, what we'll do then is we'll introduce Brandy and then go back when the others are available.
She's just rejoining. Sorry to interrupt, Andrew. She's just joining in a minute. She just disconnected. Yeah.
Okay. So you're going to go ahead then, Rabia?
Yes, Dr. Sumbul is just joining again. She just disconnected.
Okay, so we'll go ahead with that then. Okay.
Maybe we can go for any question if the participants have any question from Jill.
Yeah, Rabia, I was just concerned about our very first presentation, especially when we are referring to listening services. Isn't it something like very much closer to counseling? So I was just concerned why should we safely use the term counseling or psychosocial support? Because when we are talking about listening skills, this is something that is linked with providing appropriate support as well. So it was just my thought, just a reflection that probably safely we can use psychosocial support or counseling services.
I think, sorry, it's all right if I respond to that. I think it's tricky because these are midwives providing it. They're not counsellors. So some of them, you know, like saying in the interventions, they've received training. And I think somebody put in the chat about having the critical incident, you know, skills training. Some of the midwives have no training. Some have got MScs in counselling. So I think it's tricky for me labeling it as something that it isn't. And I think there has been work trying to define as to what we call debriefing and what we call just good postnatal care. And actually, when you look at the evidence across the services, there is overlap. Some are just really good postnatal care opportunities to talk to the women about the birth, but some do move into this debriefing. But I agree, it's a concern about label and how we label it and what we name it, definitely. But somebody, Lynn, put your hand up there as well.
Yeah, because usually as far as UK system is concerned, there's a counseling information desk available within these units. Right. And they are primarily they are responsible to handle clients in case if there's some complication in birth. And I believe that even in Pakistan, birth itself is a very complicated process. And there must be a lot of information women they are expecting from doctors, from nurses, and from like relevant paramedical staff, which somehow is missing in one way or others.
Yeah. Thank you.
I think Lynn has a question, then we'll go on to the next presentation.
Yeah, it's more of a point than a question. I made it partly in the chat, but it's become more important as you've talked. I think it's really important to ditch the term critical incident debriefing and to read all the Cochrane reviews on critical incident debriefing, including the ones around the famous obstetric study, because basically, and I teach on responses to PTSD, that's part of my world, not with midwifery, I acknowledge. is that it's bad for you. It appears, as you yourself said, to do
Yeah.
harm,
Yeah.
especially if it's universally imposed. And I think the critical incident format, which imposes the expression of emotion, does all the things that you brought up briefly, Jill. So I would ditch the term,
Yeah.
talk about postnatal support. I mean,
Yeah,
voice,
definitely.
you know, and which is, as you beautifully expressed, a step to recognizing whether somebody needs more in-depth psychological support. It's an opening. Would you like to talk about what happened? I was there. I can do it with you. What would you like to talk about? Building. You had a beautiful training, and I thought that's it. And that is not CID.
No.
And CID, read the WHO guidelines, does harm. Probably through autonomic arousal and the reliving of experience in people who don't want to relive. I'm not saying that some people don't, but when it's imposed, really bad for you. I just want to emphasize that.
No, I think that's really great. You know, I think it's really important. And in fact, a term which we've been asking parents about what they want, and it's like birth reflections, to reflect on the birth. And actually even listening, some didn't like, because who's listening? Are you listening? Am I listening? So I think that's the term that kind of commonly used in lots of services. So actually, I should have said that. So thank you. Give me an opportunity to say that as well, Lynn. But yeah, thank you for that point.
Very good. Thank you, Lynn and Jill. The other. Okay, Rabia, are we able to go to the next presentation? Or Naseem, are we able to take the next one?
Professor Sumbul is struggling to join, so maybe we
Okay.
can request Brandy if she can.
Okay, we'll go to Brandy then. We'll take another go here. Brandy, you're available?
I am. Hi, thank you.
Okay, I'll just introduce Brandy, and thank you for your flexibility here, Brandy. Nice to have you back this
Thank
year.
you, good to be here.
So Dr. Brandy Hawk earned her PhD in clinical and developmental psychology from the University of Pittsburgh. That's in the US. She is currently a licensed psychologist in the Care Center within University of California, Davis Children's Hospital. She is a co-developer of Parent-Child Care, or PC Care, a brief didactic parenting intervention. She is the clinical manager of programs providing nationwide PC Care training and offering PC Care services for children to improve the quality of visits with reunifying parents, relationships with resource parents, and interactions at school. Through collaborations, she is developing cultural and language adaptations for PC Care to better support families. We look forward to hearing from you again, Brandy, and welcome. Go ahead.
Thank you. It's lovely to be here. I'm going to share my screen real quick. All right, can everyone see this okay? Great, thank you. It is such a pleasure to be here with you all today. And I'm very excited to talk about something new that I've been working on in the past year, which is an adaptation of PC Care for forcibly displaced families. So I'm sure that you all understand this context, but just very briefly, the word forced displacement refers to people who have been forced to flee their country because of persecution, war, or violence. And this is not a new issue, and it is not a small issue. It is very large. Currently, there are likely upwards of 114 million forcibly displaced people. And in the United States, where I work, so far in 2024, and it's only May, there have been 48,600 people settled. And this is a huge number, but we want to consider also the number of forcibly displaced children. And of those 48,000 folks coming to the United States, 31% of them are under 14 years old. So we have very many children being forcibly displaced from their homes and coming to multiple countries throughout the world. I will focus on their journey to the United States. And I think what is important for us all to remember is that every single one of these children has experienced some form of trauma or potentially traumatic event along the way. And I won't go into a ton of detail here, but I think everyone who works with the forcibly displaced community understands this concept of the triple trauma paradigm, which is that these families they don't experience trauma once, but they are surrounded by it throughout their journey in forced displacement. There's trauma in their country of origin, where they may be experiencing violence and death. They are being persecuted, being forced to flee. There's loss and grief of people, of community, and there's fear. And then once they leave their country of origin, there's more trauma in the transition, the process of fleeing home, of fearing persecution as they leave, of experiencing unknown dangers and having a lack of control. Other people are in charge of their future. Going to camps, and we know that conditions in camps vary widely and are often not great. There is trauma in the transportation, how you get from place to place, and a constant lack of stability and a constant sense of unknown. And then once families make it to a host country, they're experiencing additional traumas of acculturation stress, trying to learn a new place of living. They're experiencing an uptick throughout the world, but I will say specifically in the United States, a very strong uptick in xenophobia and discrimination. There are pressures on them for self-sufficiency without any consideration of all that they have gone through. There are additional experiences of grief and loss. Once you are stable, once you are able to sit and look back, those feelings often come more. And then additionally, a fear of deportation, which again in the United States is a very strong fear for many families right now. So when we think about that context, there are a million ways that we can want to help. There are a million problems, but one person cannot support or help in all of these ways. And what we can do, we being me and my colleagues, and I think many of you here at a Global Parenting Conference, can do is support parents and caregivers. It's what we know how to do. And so how can we take what we know and use it to better support these families who are coping with so much and trying to start a new life in a new place? So I'm going to tell you briefly about PC Care, which is, as was mentioned, a program that I co-developed in 2016. It is a 7-session intervention for 1 to 10-year-olds and their caregivers. Our goals in PC Care are simple. We'd like to increase positive communication between parents and children. We're supporting self-regulation and coping skills for children and their parents. And we're teaching effective behavior management strategies to help families reach their goals, whatever those goals may be related to relationships and behaviors. We have amassed quite a bit of evidence thus far for PC Care. These are results from 2 studies that we've done. One is a prevention study in foster care. We offered PC Care to all families in foster care with the child and their resource parent. It didn't matter what the child's behaviors were. And we can see from pre to post here that children's protective factors increased, their initiative, their relationships with their caregiver increased, their self-regulation abilities increased, and their behavior problems significantly decreased. And then we also did a randomized control trial of PC Care with 2 to 10-year-olds in the primary care setting. And we found here that children's externalizing behaviors decreased significantly with treatment compared to a wait list, that the parents' total stress scores decreased significantly compared to a wait list, and that the child's adaptive functioning increased significantly compared to wait lists. So we know that this treatment is working. It is helping parents reduce stress. It is helping children reduce difficult behaviors and gain positive protective factors and pro-social skills. This evidence has allowed us to be identified by the National Child Traumatic Stress Network as a trauma treatment. We've also been labeled by the California Evidence-Based Clearinghouse as a 3 promising practice. This is a way that in the United States specifically, people are identifying what is an evidence-based practice versus not. And then by the Prevention Services Clearinghouse, which is another agency that is identifying evidence-based treatments for prevention versus those that are maybe just starting to gain evidence. We've been identified again as a 3 promising practice. So briefly, how does it work? We know that it does work. How does it do that? I think that some of the important things that we do that are different than some other interventions are that we teach and practice skills every session. There's only 7 sessions, remember. And this is what a typical session looks like. Going to highlight that in the session, we will teach new skills. And then right away afterwards, we will help the families use those skills in the moment. We typically do this within the context of play. And then we'll add in things that the family is struggling with. Maybe it is getting ready for school in the morning. Maybe it is doing homework. Maybe it's playing well with siblings. Maybe it is staying at the table while we eat. And we'll practice those things with the family. And then not only do we teach and practice in sessions, but then we assign the family daily care to go home and continue to practice these things at home. We ask them to spend 5 minutes a day playing together in one-on-one interactions and to practice the skills that they're learning throughout the day. Additionally, we teach new skills each. And so we're teaching and then immediately practicing these skills. This is an overview of what we teach in every session. I'd like to say that it's a very manualized treatment. We teach the same skills to every family in the same order, but we tailor all of the skills, all the ways that we teach it, all the ways that the family might use it to a specific family. And then in coaching, we're going to work with the family to identify what's working, what's not working, and see what feels best for them. What are the skills that resonate most with them and their values, and that they want to keep using moving forward. PC Care, we believe it should be a culturally sustaining practice as well. And for this, we do a lot in training to ensure that our providers are mindful of the different cultural backgrounds of our families and are supportive of their unique strengths. So in intake, in pre-treatment, we're consistently asking the family about their family culture, about the values that are important to them, what it means for them to be parents, and how they want services to support them. We allow caregivers to use words that make sense for them. Even though we're teaching specific skills, we want the parents to use them in a way that makes sense, with the words that make sense for them, rather than sounding like us. We use the labels and the pronouns they prefer, whether that's how they like to speak about their child or how they like their child to speak about them. And we consider the toys that are relevant to the family, understanding that the toys that I might bring to the majority of my sessions might not be the toys that make sense for a family who did not grow up in the United States, who didn't have the toys that are fun for me, that are fun for the kids that grew up playing them, but that maybe we need to bring toys that make sense for the family that they grew up playing with, that they've been playing with throughout their early lives. And we focus on strategies that work for the family's household. Again, every session we're asking the families, what do you think of these skills? How do you think you're going to use them? Do you think you're going to use them? What are the ways that they are going to actually work for you? And within our this understanding of PC Care in general being culturally sustaining, we also know that we need to develop adaptations when necessary. And for that, we realized that we do need adaptation for forcibly displaced families, that PC Care as it is great for a lot of families, but there are unique needs of these families that we needed to address and consider. So in order to do that, we collaborated with experts. So we're experts in a lot of things. Working with forcibly displaced families is not one of those things. And actually, the start of this began with folks at the International Rescue Committee's CARE program reaching out to us to see if we would be interested in collaborating. So I am so incredibly thankful for them. They have an NCTSN grant, a National Child Traumatic Stress Network grant, that is specifically to create cultural adaptations of evidence-based treatments and to review and adapt materials specifically for forcibly displaced families. And they, in all of this cultural adaptation review, creating adaptations of programs, they also include translations, both a cultural adaptation and a language translation of the concept. And specifically with us, we've been working on these translations in Dari, Spanish, and Ukrainian to address the needs of some of the folks who are coming to the United States. So thinking about a cultural review. So they sent all of our PC Care materials, did a small training for individuals who are part of these communities, who have been forcibly displaced or who have immigrated, who are from these countries of origin, cultures of origin. And in general, what the cultural reviews found is that our content and format work in different cultures. They said there's no need to change the specific skills that we teach, no need to change the concept of daily care or how it's presented, and there's no need to change the session protocols. But we do need to split pre-treatment into 2 sessions. And we also need to continue to use our standard culturally sustaining practices for the toys and the family culture and context. But there were also some things that we do need to change. And I'm going to walk through some of those. So we need to adapt the measures. So as an evidence-based treatment, we require folks to do a behavior and a trauma screener of everyone who goes through PC Care, because we want to be sure that we are assessing what's going on and we're being able to address the things that are concerning for the family. And you can see this is the kinds of feedback that we receive when the measures were sent to the cultural adaptation team. Some of their main feedback is simplify the wording and expand instructions, disclaimers, and explanations. And so we would see things like some words don't exist, like the word emotional abuse did not exist in Dari. And so we needed to explain that concept so that people understood what we were asking about. We also were given feedback about how time is measured differently. So on this feedback, you can see dates do not exist as a measurement of time in the Afghan culture. And it would be more culturally appropriate to put approximate age in year rather than what was initially requested, which is approximate age and date. So there's a number of these changes that needed to be made. And then a specific explanation of the impact of completing these measures on legal status and who has access. We know that they're not going to anybody who would be able to take any legal action on these families. It's not going to go to anybody who might be involved in deportation, but the families don't know that. So we need to be extremely explicit right up front about the purpose of the measures and who has access. We need to do slight adaptations to our education. We do education about trauma-related behaviors in children and stress-related behaviors. Our cultural adapters told us that trauma is a word that isn't always understood and can mean very different things, and that the families are going to resonate more with the idea of stress in the displacement process. And so we created a stress-related behaviors, but we added context about the trauma of forced displacement specifically and what it means for kids to have gone through this experience. And then after we go through the symptoms of stress-related behaviors, we added additional context at the end. So we've kind of sandwiched the symptoms in between the context and added in when to ask for additional help. Even though you're in a service that is helping you, if you see specific symptoms, make sure you tell your provider, because they are there to help you get additional help if necessary. And we adapted forms, which are some of my favorite things that came out of this. They had an amazing illustrator create abstract pictures for all of our different skills that we teach, so that there was no cultural connection, that no one could say, I don't see myself or I do see myself in these pictures, because they're so abstract that everyone can kind of see themselves in them. We also created these as flashcards and as regular handouts. So typically we give a handout each session with all of the skills. And for this, we created flashcards so that they could focus on just the picture and have less written content for families who don't read very well, right? And who are going to resonate better with a picture and conversation. And some of the examples were changed to be more culturally relevant as well. And we had to adapt acronyms. So if there's something that we love, it's a good acronym. And it's fun to come up with acronyms. And when you do translations, they don't work anymore. So one of the acronyms that we use in PC Care is PRIDE. These are our positive communication skills, and it stands for praise, reflect, imitate, describe, and enjoy. When you translate into other languages, it no longer means pride. And so the groups had a really great time trying to figure out what's our new acronym going to be. And you can see in Ukrainian, they found this beautiful word that means to express warm approval that they use instead of the word pride. In Spanish, we have a word that means daily, right? Because we're using these skills daily. And in order to create that word, they added a skill of offer affection. And in Dari, we found a word that means proud and honor. And also to create that word, they added a very important cultural concept of acceptance into the pride skills. And then very briefly, what are our outcomes so far? They're very, very small because we are just finishing up training of the staff at the 2 pilot programs. Our initial feedback from our trainees are that they very much like the PC Care program, and they're very happy with the adaptations, and they think their families will enjoy and benefit from them. And we have one of our providers who has completed training and is working with families, our Ukrainian families. And these are very early data from just 3 families, so take them with a huge grain of salt. But you can see across at least the first 3 sessions, this provider's families are reporting decreases in their children's difficult behaviors. And we're seeing increases in the parents' observed use of positive communication skills. So it does appear that at least these first 3 families that are going through PC Care are finding value and that it is making a difference for them. So conclusions, evidence-based parenting programs like PC Care can be adapted to better support forcibly displaced families. I think we all knew that, but I'm just going to say it. But it is important to remember that thoughtful adaptations require input from many people, and that those people need to be part of the community and understand the language and the cultural needs and values of their families. Thank you very much.
Thank you, Brandy. This is wonderful to see some new things that you've developed and building on what already is a strong service. And I know that what you're doing, this could be of great interest to others who are attending this conference as well. And we encourage you to make those contacts and learn from them. And I know Lynn Jones is in the same work. I get a sense that Jill would be very interested as well. And I know that there's others who would be very interested in communicating with you. So thank you very much, Brandy. Appreciate it.
Thank you.
So I think, Robbie, if it's okay, I'd like to go to Marie Yap. And if that's all right, unless you have another suggestion.
We have Dr. Sambal with us.
Okay. All right. So if Marie Yap's okay to just wait for it to be the following one then. Okay. Naseem?
Yep. Welcome, Dr. Sumbul. We've already introduced you to the group. So over to you. You're mute, Dr. Sumbul, you're mute.
Okay.
Yeah.
Sorry. So thank you very much for giving me this opportunity to talk on this psychiatric ailments. So actually, I was thinking of doing a paper on the fetal demise and its cause of post-traumatic stress disorders in fathers. I was in England and we were attending an RCOG conference where for the first time about 4 years back, there was a whole plenary session on post-traumatic stress disorders in fathers. Never heard of it in our country. So this really interested me. So I said, let me go through a lot of literature and then I plan to do this study in my own country. So this is a little insight to what I gathered from the meta-analysis regarding post-traumatic stress disorders in fathers. So this was my topic and we're doing a study of it in Pakistan because never a study has been done in the in poor countries like Pakistan. So this was a new insight for me, and this is all the papers that I went through in order to get my study into action is what I present over here. Thank you. So is fetal demise. So we've always know that the cultural expectation for fathers were not actually very much involved during pregnancy and childbirth. And as such, no social and psychological support was given to the fathers in response if there was any tragic event, especially in developed countries like Pakistan. But as I went through a lot of studies, it was found out that the fathers wished to be included in perinatal health care, and they did want to be included by the healthcare professionals regarding the health and well-being of their unborn child to that of a neonate. And this was probably not understood very much in our part of the country. So, these studies were actually all done in the Western countries. And we thought that doing it in our country would give us insight to the Western psychiatrists, how our men would actually behave. So it has been shown that complications occur, stress can be extreme on fathers with long-term consequences. Psychological consequences of a traumatic perinatal event such as fetal loss and its impact on fathers is, however, less well understood. Fathers may develop a classical grief response with public grief suppression to conform to the societal expectations of masculinity in them. There is a great concern that exposure to the traumatic circumstances in pregnancy and childbirth may contribute to post-traumatic stress symptoms in fathers. Now, what is post-traumatic stress syndrome? Post-traumatic stress disorders is a kind of a persistent syndrome of symptoms relating to traumatic events which usually arise 1 to 30 days after exposure to actual or threatened death or serious injury. It is characterized by intrusion of traumatic memories, changes in cognition and mood, and arousal and reactivity. Fathers with post-traumatic stress syndrome can be associated with exposure to hospital environment, similar sights and sounds like of neonatal intensive care unit, paranoid ideation, and phobic anxiety.
Sorry, Dr. Sumbul, are you moving your slides? Because your slide had stuck to the second. I don't know if you were. Is this the slide that you are on now?
No, actually, it's not moving because I was not supposed to move the slide.
Please let me know when you need to move the slide.
Okay.
I'm handling your slides. Please just let me know.
Please kindly move the slides. So next one, please. So now for fathers, it's a natural to experience psychological distress and grief reactions after any perinatal loss. The loss of a child goes together with the loss of expectations, hopes, and dreams. But in some cases, it can be more severe, as research indicates that there can be many psychological, physical, social, and financial consequences to this post-traumatic stress. Fathers actually experience feeling of anxiety, depression, and post-traumatic stress symptoms, but easily ignore it or compensate it through habits like substance abuse or focus on work and specific other tasks. Yes, please. Change it. Now, what are the predictors of grief? At an individual level, there are mixed findings relating to demographic factors, suggesting that these have not been actually been well explored. Similarly, personality constructs may play a key role in predicting grief, although further research is required to confirm the causality. However, in contrast to early assumptions that men only develop an attachment to the developing baby as gestation increases, however, results suggest that attachment at any level is an important predictor of grief. It can either be an early miscarriage or a late preterm death. Yes, please. Can you change it? Now, I was going through a lot of systemic reviews, and all have highlighted of developing the stress disorder in 16% of all men, although these symptoms tend to remain postnatally after the birth of an alive baby. They tend to reduce. However, in some, about 8.4% of fathers, it may be a long-standing event and may extend up to even 18 years after death of an infant. However, it is said that lower gestational age is associated with more severe symptoms. Yes, please. Fathers who have suffered a fetal loss may need specific assistance at certain times along, maybe with extra psychological support. The need of the day, however, is more widespread screening and assessment of fathers for paternal perinatal depression, and it is very important to assess fathers' mental health status earlier in pregnancy. Yes, please. Screening for mental health concerns should be routinely done for fathers before or during pregnancy and also in the postpartum period. Post-traumatic stress disorder and depression significantly develop the infant development. So we know that how important it is for the father to be in a normal mental health. Therefore, there is an urgent need to provide support and intervention for fathers who have experienced adverse fetal and neonatal outcome. Yes, please. There is also a widespread consensus that grief is a multifaceted and highly individual process. There is a need to increase the accessibility of support services for men following pregnancy or neonatal loss and to provide recognition and validation of their experience of grief. Now, there is a dual process model of coping with bereavement, which is described an ongoing oscillation between loss-oriented, that is emotional, and restoration-oriented, that is problem-solving coping strategies must be put into action. Specific to bereaved parents, the Contouring Bonds approach recognizes the need for ongoing connections through symbolic objects, rituals, and sharing memories. Research on gender and grief has found that due to social expectations surrounding how men should behave, men are generally less likely to outwardly display their emotional reactions, may also experience more difficulty than women in seeking or accepting help for mental health concerns and grief, and of course their losses. In 14 quantitative studies, men reported that the loss of the baby was a significant life event regardless of the gestational age or neonatal age. Keeping busy and then moving forward were common desires, seeking out distractors, including sporting activities or increased exercise, returning to work, completing household tasks, and creative hands-on outlets such as woodworking or painting or writing. And another 10 studies also reported outward emotional grief expressions such as crying. They were frequently kept private. However, certain men like to keep them private, with many preferring to grieve independently or alone. Yes. Finally, I was going through research on gender and grief and found out that due to social expectations surrounding how men should behave in the society, are generally less likely to outwardly display their emotional reactions and may also experience more difficulty than men in seeking or accepting help for mental health concerns, grief, and adjustment to this loss of theirs. In another 5 studies, it was found out that men stated that they did not feel that they had a relationship with a developing baby because it was too early a loss, either because it was an early miscarriage or described little involvement during the pregnancy. Others also made a conscious attempt during pregnancy not to get attached due to the previous experience of loss or diagnosis of a life-threatening condition. And in these cases, grief was reported to be less when men were not actually associated with pregnancy. Actions that increase attachment include spending more time with the baby and attending ultrasound clinics, going with the wife to the doctor, and to hear the heartbeat. One qualitative study measuring grief after seeing or holding the baby identified worsening of the grief for men. So that was that bonding of the baby with the men did produce more grief. Yes, please. Now, importance of quality of partner relationship to grief. In 10 qualitative studies, it was noted that partner relationship could have either a positive or negative impact to the grief experiences. For many participants, in absence of any professional help, their partner became the main source of interpersonal support. Yes, please. Now, the supporter role, one of the most consistently reported and important elements relating to men's grief across qualitative studies was being a supporter to their female partner and family. Suppress or put aside their own grief to take on this role to provide a supporting role for their wives or partners. Acknowledgement from family and friends. It was found out in 16 studies looking at support. 10 found family or friends to be a helpful facilitator to men's coping following the loss. This was important since many men explicitly reported a preference not to engage in formal counseling and support groups. So acknowledgement of family and friends is a very important factor. From healthcare professionals, role of healthcare professionals was recognized as essential to the bereavement process. Yes, please. Now, socio-ecological model in men's grief is that the public policy factors, then community factors come into play, then interpersonal factors, individual factors, and they all end up in individualized grief experience. So this is what it is, the whole factor which we should all work upon. Now, what is the attitude of the community? A general community attitude that pregnancy and subsequent loss was primarily a woman's experience, not anymore. Men also reported feeling overlooked or ignored in the context of existing healthcare and support services. For example, in the hospital environment, both following loss and during subsequent pregnancies, men felt out of place, marginalized, and sometimes they thought that they barely existed. 5 studies also expressed a desire for recognition for the men, as well as a need for increased male involvement in care and support services. Yes, please. So community education is very important. There is also a need to educate the community about the impact of pregnancy or neonatal loss on men, as well as promoting their strength to seek and accept rather than to avoid the support. Stigma surrounding male seeking help frequently serves as a barrier to assessing appropriate health-related supports. Strategies are also needed to develop male-inclusive healthcare practices and promote the meaningful engagement of men as equal partners throughout pregnancy. In the broader context, postnatal health engagement of father has demonstrated an equal long-term physical and improved health outcome for men. Yes.
Dr. Sumbul, you've got a couple of more minutes.
Okay, so there's involvement of religious activities. However, impact of cultural diversity is yet to be explored in men, and cross-cultural studies with women highlight a range of culture-specific understanding and practices relating to the loss of baby that can impact upon grief. Yes, next, please. So male expectations and attitudes towards men grief. Again, it is very important to have a strong and a perceived expectations to hide their grief. Next one, please. It's very important for healthcare professionals to provide sensitive and empathic care to both members of a couple and relationship. Practical information should be provided in our setups. Yes, next one, please. Follow-up calls, especially for women and for men in the weeks or months following a loss, should be made. Solid communication between healthcare providers from all ties surrounding these parents is very important, and proper support system should be provided. There are controversies that the concept of trauma is still controversial and highly debatable in the literature. On one hand, it should be considered that PGD can turn normal grieving responses into a mental health condition. It is also suggested that diagnosing people with PGD after a loss can help them better understand what they are experiencing and get appropriate treatment. Increased need for support of services. Future resorts should be more consistent in describing the different types and timings of loss. It is very important that healthcare providers involved in taking care of parents facing perinatal loss are proper trained in providing support to them, and they should be at least able to provide explanation to the bereaved parents about the grieving between partners and skill to navigate the potential issues. We can assume that fathers can be at higher risk of developing depression or post-traumatic stress syndrome. However, this gender role has mainly been researched in the Western countries, and more studies need to be done in the poorer countries in order to understand our prospect of bereavement in fathers from our part of the world. I thank you very much.
Thank you, Dr. Sumbul. Thank you for your time. And thank you for being an OBGY consultant, thinking of fathers as well, and thinking of this important area. We have in Pakistan Institute of Living and Learning, we've done a very large study on depressed dads. There's a presentation tomorrow, so you'll be welcome to attend. We are running short of time, so if there are any questions, Rabia is going to forward you from the chat later on. But thank you very much. Thank you for your
Thank you.
time.
Thank you very much. Thank you. Bye.
So the next speaker, Andrew, over to you to introduce.
Yes, thank you. Marie Yap is, I can see her name here, so I hope she's ready. She's a professor and psychologist at Monash University in Australia. And I was surprised when I looked it up that there's 85,000 students enrolled at that university. I find that amazing. That's a large one. She's the founder of an award-winning parenting strategies program, which translates research evidence into actionable parenting guidelines that underpin a suite of individually tailored online parenting interventions to prevent and reduce the impact of mental health problems in children and adolescents. These online resources have formed the basis for parenting programs and resources in over 20 countries. Recognized by Expertscape as a world expert in family relations, she has extensive experience developing and implementing scalable digital parenting programs that have improved parenting and child mental health outcomes. Her parenting resources have been rolled out nationally in Australia and adopted in UK, Canada, New Zealand, Norway, Romania, Malaysia, China, and Singapore. She has authored 110 peer-reviewed publications and secured over $30 million Australian in competitive research funding from national and international sources. She co-chairs the Scientific Advisory Committee of Growing Minds Australia, the first national clinical trials network in child and youth mental health in Australia. Maria, we are very happy to have you present at this conference again. Welcome.
Thanks, Andrew. Thanks. And thanks again, Rabia, for the opportunity to join you at this conference for a second time this year. Just let me share my screen. I think I'm sharing the wrong screen.
Yes.
Sorry about that. Bear with me. Okay. Is this the right one now? Okay, great. So I've titled my presentation today, "So the Intervention Works, What Next?" I wanted to kind of make it like a sequel to the presentation I made last year for those of you who were here, but for the benefit of those who weren't in the conference last year and heard my presentation, I'll give you a bit of a brief about the suite of interventions that we have developed over the years. But the focus of today's presentation, I wanted it to be more on the kind of the next steps beyond the initial evaluation of an intervention after establishing that it seems to have some efficacy. So I'll just kind of give you a brief background. First of all, to the, sorry. Are you able to see my screen, like the actual slide presentation?
It says outline is the heading.
Yeah. Okay. Sorry, there's I think it's working now. So just quickly, I'll talk a bit about the Partners in Parenting intervention and how we developed that, and then the evidence base behind it that we have established in the initial years of after we developed it, and the next steps that we have taken since that. So just quickly, the Partners in Parenting program started about 10 years ago, 10 to 15 years ago, at which time there had already been decades of research into the role of parents and carers in children's development and well-being. But it was apparent that most parents in the general population don't actually access the research evidence or benefit from it. So I was at a crossroad in my early career, early research career, where I recognized the need for research translation. So actually translating the evidence base into accessible resources for parents so that we can actually benefit families who have been researched on, so to speak. So that was kind of an endeavor that I started out on about 10 to 15 years ago. And that then saw the birth of the Partners in Parenting program. So we started off back then in 2014 with a systematic review, a meta-analysis of parental factors that were associated with depression and anxiety in young people. So as I mentioned, there have been decades of research even at that point, lots of different studies. And there was robust evidence showing that 4 parental factors that are potentially modifiable could increase risk for both depression and anxiety in young people, and that included having lower levels of parental warmth, higher levels of interparental conflict, over-involvement by parents in children's lives, and high levels of aversive parenting, which were measured in the form of criticism from parents, harsh kind of parenting, and high levels of parenting conflict. There was also evidence for 2 additional modifiable factors that were specifically in terms of increasing risk for depression in young people, and that was lower levels of autonomy granting and lower levels of monitoring, which was measured in the form of parents knowing where the young person is when they're not with them, what the child is doing, and who they might be with. So we then kind of recognized how, like there's all this evidence base, but it's not always clear to parents, in the general population, the community, even if they were to pick up, the many publications that we researchers publish, in academic journals, because it's just not presented in a language or form that parents will be able to find accessible or understandable. So, for example, parents might find, even if they were to read about research that's been published, if they found out that there was a sound evidence base that over-involvement increases risk for depression and anxiety, that might not necessarily tell them what positive involvement would look like, or when that might tip over into being overly involved. So it was a tough balancing act to expect parents to be able to make. So what we then endeavored to do was a Delphi study to obtain international experts' consensus about what should be recommended to parents, and in that process translate this evidence base, which is very much written in academic terms, into accessible knowledge and resources that parents can actually benefit from. So as part of that study, we identified over 400 unique recommendations that were readily accessible to parents online. And we recruited an expert panel comprising 23 international experts with either research or clinical expertise in parenting and youth mental health. And from the process of the Delphi methodology, we then siphoned down to 190 of those 402 strategies that the expert panel endorsed as important or essential, and there was agreement with at least 90% of the panel agreeing that these 190 strategies were important or essential. So the result of those 2 studies, systematic review and the Delphi study, were a series of parenting guidelines that we then made available. So the one on the left, you can see, is the original one that we published in 2014. And we then had a COVID-19 update with additional strategies for parents to support their child's mental health during a pandemic. Using a similar methodology, we published guidelines for parents with younger children. So for this one, it's for children aged parents of children aged 5 to 11, and we also had guidelines on adolescent alcohol use for parents as well. So beyond just providing parents with kind of a set of PDF text guidelines, essentially we wanted to also help parents to action and implement these recommendations. And because of the universal prevention approach that we were aiming for back in 2014 when we 2014 when we first developed the Partners in Parenting program, we decided to go with a technology-assisted option, which meant that it was an online program that parents could access. So the program comprised a self-assessment scale that essentially assesses where parents are at relative to what the parenting guidelines recommend that they do. And upon completing that scale, parents get a tailored feedback that's personalized to them, that highlights areas of strengths and providing specific strategies they could use to further develop in other areas in their parenting. And all of that was presented as part of a web-based parenting program that we made available, now known as the Partners in Parenting Program. So what we designed was a program that is multi-level, and the idea is that at the basic level, level 1, which is essentially the parenting guidelines that I just talked about, it will be appropriate for kind of universal prevention kind of approach for all parents, regardless of their child's risk or the parents' concerns. With that, with the next level up, essentially the parenting guidelines, but in a form that's personalized. So we call it single session, brief intervention, where parents get the parenting guidelines personalized to them upon completing the self-assessment parenting scale. With level 3, they essentially get the single session intervention as well as interactive online modules that provide additional troubleshooting and problem-solving tips for them. And as we go up the levels and right up to level 4, we are looking at supporting parents whose young person is already clinically unwell and or the parent themselves are struggling in their own parenting skills and confidence and are really seeking additional support beyond what an online-only program can provide. So that's the overall multi-level approach that we went with in the Partners in Parenting Program. So just a couple of stepping through what the program might look like. Someone can register on the website just with their email and creating a password, and then providing some demographic information, which we then use specifically the name and the gender of their child to personalize the survey, which is the self-assessment scale that I talked about. So upon completing the survey, they then get personalized feedback in 9 different domains of parenting that the evidence base has highlighted as being important for their child's mental health. So as you can see here, they can click on each of those domains and get personalized feedback on areas of strengths and specific strategies that they could use as well. So when they then move beyond that personalized feedback, they can then access the online interactive modules that we have also developed across the different parenting domains. And the program is designed to be adaptive. So for a full-size screen, like a computer, for a phone, or for a tablet kind of size device. And across the program and the modules, we use a series of different interactive activities, illustrations. We have a goal-setting exercise, which parents are encouraged to pick a goal and work on for the week coming before they move on to the next module. And we also have a series of different videos where we enact parent-child interactions and the dynamics therein and talk about, which aspects are helpful and which might not be as helpful. And then each module ends with a quiz to consolidate some of the key messages of the module for parents, and immediate feedback is provided to parents as they respond to each of the questions in the quiz. So just very quickly, we have done a series of different evaluations for the program across the different levels. So for level 1, we've done an online survey, which basically just invites people who download our parenting guidelines to come back and tell us a month later if they found the guidelines helpful in any way, and if they endeavored to make any improvements or changes in the parenting in the different domains that the parenting guidelines covers. And from that survey, we did find very promising effects with majority of parents who access the guidelines reporting that they tried to improve in their parenting across most of the domains in the guidelines. We also did a randomized controlled trial to evaluate that level 2, which was a single session intervention, and found promising benefits on parenting in a pre-post compared to a waitlist control group. For level 3, we had active control where parents got online fact sheets on parenting and child development, and we compared that to our interactive online modular program and found promising benefits, both in terms of parenting and then in the 12-month follow-up with the mediational analysis. We found that improvements in parenting also led to improvements or reductions in adolescent depression symptoms. For level 4, we've done a single arm double baseline trial to clinical trial to evaluate the clinician supported version of our online program, and again found very promising effects from that as well. So essentially, we kind of come to a point in the intervention kind of journey and found that, well, overall, the program seems to help families. Families seem to like it. So what next? What do we do next? So I've just kind of pasted, this is a very simple diagram. Some of you will be familiar with it. It's a prevention science research practice cycle. And essentially, we've kind of gone through the cycle at least once with the different versions of our program. So we started off with recognizing, defining the problem, did a systematic review in Delphi study to kind of identify and kind of, distill the parenting strategies or the risk and protective factors that can be targeted in the intervention. We then developed the Partners in Parenting program, did the randomized controlled trials. And then we kind of reach a point where we're like, now the program seems to help families, what do we do? And so then the next step was to try to roll it out more widely and make it accessible across the nation. And as you might have heard, I'm based in Australia. So now the Partners in Parenting program is available nationally in Australia through Headspace National, which is a national youth mental health service that's funded by the federal government here. But beyond that, we know that there are a lot of limitations both in the broader literature and the evidence base, but also limitations in our program. Particularly, it's not reaching everybody who can potentially benefit from it. And so what can we do about that? That was a big question that really plagued me at that point after we found the initial evidence of efficacy. So that kind of really drove the next stage of our work in terms of wanting to find ways to address the limitations and to increase the reach and the benefits of our program. So just quickly touching on some of the challenges and opportunities that we have identified. So in terms of challenges, as I mentioned briefly, it's the uptake, so we know it's nothing unique to our program at all, but we know that there are lots of evidence-based parenting programs available nowadays. But the uptake is limited. So just because a program is available doesn't mean people will use it or that they would know about it in the first place. So there's the motivation to engage in parenting programs as well, especially when it's a program that's about child mental health. So there's almost like a double stigma involved because parenting is in itself a sensitive topic. So to tell parents that they need to do a parenting program, it's then perceived as telling me that I'm a bad parent. And then if you're talking about child mental health in itself is still very much a stigmatized concept even in Australian society. So to talk about doing a parenting program for your child's mental health just comes with that double whammy. So the motivation to engage in parenting programs is something that continues to be a barrier in quite a few ways. The reach of the program is what I was alluding to when I said, there are certain pockets or certain subgroups in the population that we continue to fail to reach across all the available programs. All of which wouldn't be surprising to the audience here, I'm sure. But essentially, most programs that exist nowadays reach the middle, upper class, highly educated, highly motivated, generally well-functioning families and parents. So we know that there are the rest of the population of families where the parents could potentially benefit from the support and having access to evidence-based programs, but they are not being reached adequately by programs. And so that's something that we identify as a challenge for us to address as program developers. How can we serve their needs better? Engagement, of course, we know that when programs are made available, people might enroll if you even get them through the door, but they don't stay on and complete the program. So that's an ongoing challenge, again, not just for our program, but for lots of evidence-based programs out there. And then, of course, there's the sustainability question. Once it's been shown in a research trial to be useful, what next? Who is going to pay for the ongoing access to the programs? And it's the same challenge. There's the same question that applies whether it's a face-to-face program or an online program. But of course, in the context of all that, there's also lots of opportunities. So, we know that digital technology is advancing very rapidly in most developed countries and across developing countries as well. There's increasing access to digital technology, and the digital divide is also getting smaller in many countries. So we know that that we can actually capitalize on the ubiquity and the rapid advances in technology to help address potentially some of the challenges that we have that I've mentioned here. Another approach that has been recommended by scholars in the field and in prevention and in mental health is the idea of embedding these programs into existing settings. So making it accessible and available where people are actually looking or actually present, so if we know that parents are online for a significant part of their daily lives, then making it promoting the availability of these programs through these online social media platforms that they are on, perhaps is an approach that people have tried. Of course, we know that most children are enrolled in an education institution, so that then provides the opportunity or a setting in which, we can make available and raise awareness about the existence of some of these evidence-based programs, for example. And then, of course, if we're looking into early intervention in the context of health services and access in health services for families who have concerns about a child's mental health, there's also the opportunity, if the evidence-based intervention can be integrated and embedded within those settings, then there is the opportunity to increase the access of those programs as well, and to look at ways to integrate the programs into existing health services in that particular health service setting. So those are just different opportunities that not just my team, but others in the field have been looking into, and to really try to address some of the challenges that I have mentioned here. Included in all of that, of course, there's looking at different contextual factors as well. So one of the things that we are starting to do is looking at how our programs could be adapted for different cultural groups and different countries as well, and looking at what level of need there is, in terms of adaptations. So, if you have countries that have more or less kind of similar types of compositions of cultural perspectives and values, then, so for example, with the work that we've done in the UK, the general finding is that there's more similarity than differences between Australian and UK families. So the adaptations that were required to create a version for the UK were actually really minimal. But in the work that we're currently doing with Malaysia to adapt the program for Malaysia, it's a very diverse and very different composition of cultural diversity there. So the localization and adaptation efforts are a lot more substantial. So looking at ways not just to make it more culturally adapted and appropriate, but also looking at the types of digital technology and platforms and formats that might need to be considered to make it more accessible and relevant for the population that's in that country. So even considering some of those contextual factors as well to be able to tackle the challenge around reach and access for these other populations. So I'm just going to end there. I'm not sure if there's any time for questions, but I'm happy to take any.
Thank you very much, Marie. If people have questions, just put them in the chat box. Marie can check those and get back to you. Marie, I'm very impressed that you're willing to share about some of the difficulties or challenges of uptake, and it's a wonderful presentation there. When I was hearing it, I thought, well, I wonder whether learning through play, which is mainly focused on low-income countries, what would happen when you start thinking about putting that together, or somehow seeing whether there's some learnings that could happen between the two systems there, two programs there. And the digitalization, I know there'll be lots of interest in that kind of work there. That's something certainly of the future and the present. So thank you very much, Marie, again, and we wish you well in the continued development of the work you're doing. Nicely done.
Thank you.
We're going to take a break now for about 9 minutes. And if you wish, during that 9 minutes, if once you've had your bio break or whatever you need, is you can unmute yourself and say hello to the colleagues or friends you know around the world, and we'll get back in about 9 minutes then. Okay? Thank you.
So, Rabia, can I take this opportunity to make sure my slides work? Okay, because I'd like to control the slides myself. So that means allowing me to screen share?
You are allowed. You can share.
I am allowed. That's wonderful.
Hello, Shadamina. Hello, how's everybody doing? I wanted to give a special shout out to Maya. Hi, Maya, how are you doing? Can you hear me? Maya from India.
Lynn, you can share your screen meanwhile.
I'm just getting my slides up. Yeah, I'm just sorry, it took me a minute. Okay. I have to have them up before I can share them. So there we go. There we go. You are screen sharing, and now is that coming up? Can you see my slides? Hello?
Good morning, Nancy.
Yes, they are visible. Yes, they are
Nancy
very much
Cohen,
visible.
how are you?
I don't know. It's not showing on the, I don't quite know what to do. Okay, try again. I'm sharing, but it's not appearing. Try again.
I can see your screen, Lynn.
Well, I can't. Why not?
It's not presenter view. We can see
It's not.
the
No, I
notes.
know, but I can't even see outline view. I usually, once I can see it. Okay. Let me see. I don't know what's gone on here. If I can't see my slides, I can't do it.
We can see your slide.
I can see everybody, and I can't see.
Just try to press F5. Maybe it is in the processing mode. F5.
I see your slide.
Yeah, but it's no good if I can't see them.
Oh, yes, that's a problem.
Lynn, did you say that you can see everybody?
I can see everybody, and I can't see what you normally see when I do a slideshow.
So have you reduced the people to one side? In other words, put the what do you call that? What if you put?
If you click on the slide share button.
Yeah.
Are you now seeing my slides properly?
Yes.
Yes. But you're not seeing my notes, I hope.
Yes, we can't see your notes now.
You can?
No, we can't.
Okay. Now I've lost you altogether because I've just gone to the slideshow. Oh dear. I could do that and do it blind, but it's better to be able to see your faces. Let's try again. Okay. Don't know what to do. I either have the chat. I'm going to start again. Okay, you're saying get rid of. How do I get rid of the faces, Andrew? You were saying.
If you go down to on the top right corner, it says view, and then go down to full screen, and then, or go to speaker or go to,
Yes, that will do it. I've got speaker now.
okay.
Maybe that's what I need. If I'm on speaker view, yeah? Now
Yeah.
let me try. That might have been the problem. Okay. I've got to
I'm
go
not an
with-
expert in this. Maybe some of the folks there at PIL would be able to help.
I think that might have been it. Okay. Now.
Some of you folks who have made presentations, it may be that you know what if you have a suggestion, please,
No, I think it's going to work now.
okay, there. I can see your slide.
Yeah, and now let me just put this over to the side. And let me go to presenter view. I just don't, right. You can see my slide, but not my notes. Is that right?
That's right.
Right.
I'm there. Thank you so much. So I know what to do. I just have to go through those steps when it's my turn, because I know I'm not the first. I'm the last speaker or the middle speaker. I can't remember.
You're the third speaker after the
Great.
break.
I'm
Good.
ready. Thank
Okay.
you for that. Good that we rehearsed. Thank you very much. Okay.
Yeah,
Well,
I'm delighted to see Lema Asfa from Ethiopia here, I think.
Thank you, Andrew. Greeting all. Thank
Yeah,
you.
and see Julie Bolin is here. Delighted Julie's been attending each year. Nice to see you.
Thank you.
I've stopped sharing. That's okay. Yeah. Right.
I'm Rubina Hussain from Karachi, Pakistan, President of the Pakistan Menopause Society.
Yes, welcome.
Thank you. I'm one of those early birds who like to check in early.
And I think I met Carrie Greer at an earlier presentation in Toronto.
Hi, yes. So happy to be with you today.
Nice to see you.
And I look forward to catching up in boring old Toronto compared to all these exotic locations.
Well, nice to have you with us, Gary.
Lovely to be here. Thanks.
Okay, another minute and then we'll get started. And just one more moment.
Lynn, if you can please stop your screen.
I have.
We still see your slides.
I don't know how to stop that. I've closed my slide. Can you just stop me sharing? I don't know what to do.
No, we would not be able to stop your screen. Yes, now
Okay.
it's gone. Thank you.
Okay.
Thank you, Lynn. And should we start?
Yes, is Naseem
Yeah,
and
I
Naseem
think
available?
most
Okay.
people are back as well. Yeah.
Naseem, okay,
Welcome
go
back,
ahead.
everybody. I hope you've had a little rest. So we'll move on to our last session. So we've got some excellent speakers, excellent topics. And our next speaker is Dr. Salman Shehzad. Now, I'm very grateful to Salman because he has had a really big conference today at his university, which he had organized. And I'm not sure, Salman, whether it's over or not, but you are here with us today and now. So thank you very much for this. Salman is a professor of clinical psychology. He's a consultant psychologist and clinical in charge of at the Institute of Clinical Psychology, Karachi, Pakistan, University of Karachi University. Dr. Salman is also the lead for research and training unit for prevention and treatment of substance use disorder. He's a coordinator, focal person for Pakistan International Consortium of Universities for Drug Demand Reduction. He has a professorial research scientist Head of Division for Substance Misuse, lead psychosocial interventions at Pakistan Institute of Living and Learning, and he's also the national lead portfolio for mental health, Aga Khan Health Board for Pakistan. So welcome, Dr. Salman, and over to you.
Thank you so much, ma'am. And it's lovely to see you all the mentors and the collaborators of Pakistan Institute of Living and Learning. And thank you so much for giving me an opportunity to talk about one of the important parenting program, which is called the Strong Family Program that we are going to implement here in Pakistan. Professor Masim, my conference is still going on, and Professor Imran Bashir is going to have a wonderful speech in the closing session. So I requested them to spare me for a few minutes, so they accepted my request. So I am over here to join you for my presentation. The Strong Family Programs here, this is developed by the UNODC, Professor Dr. Ala. So when I see in one and the Professor Dr. Ala about the parenting program. So we started our dialogue and a discussion about how can we bring this program to Pakistan. And thanks to them, and thanks to Professor Nusrat Hussain, who is always at our back to push us, to support us, to guide us. And he said, okay, wonderful, bring this program to Pakistan. And we started discussion with them through the platform of Pakistan Institute of Living and Learning. And they accepted our request. And now we are off to a fabulous start here in Pakistan of the Strong Family Program. The Strong Family Program is a family skill program that is one of the evidence-based prevention program, which builds the family skills and support caregivers, especially the mother and the parents, even he or she can be the aunt, uncle, to be a better parent and strengthening the positive age-specific, age-appropriate family functioning and interaction with their kids. The main components of this program is to strengthen the family structure as well as function and help the families to prevent drug use, not only drug use, but also the violence and the neglect and the abuse related issues in the life of the kids. So next slide, please, Rabia. So this is one of the few glimpses of our program. We started the training capacity building of our national program leads as well as the psychosocial team members in different provinces, in 5 provinces and in different cities of Pakistan from 25th of April to 28th of April across the country in 10 cities. Once at a time, we implemented this training program in Pakistan. Again, this is a part of this training program, this Strong Families. We conducted the virtual training, and it was the 5 live webinars, which comprised of the 2 hours each day. And we had a wonderful experience. It was an experiential learning for all of us, and I personally attended this program. So we had the role plays, practice session during the live our sessions, and homework assignments to do, and how can we replicate these sessions, especially the activities with our kids. And after the homework assignment, our main trainer, Dr. Allah, was reviewing our role plays as well as the assignment that she had given us the assignment. After conducting the training, we took the feedback from all the participants who attended this training program. Everyone was so excited, and all of them were looking for such kind of programs to be implemented here back in Pakistan. And this is one of the program which is very easy, and the hands-on experiences. They had wonderful experiences, and the role plays were very clear for the participant, and what was the expectation, and what are the outcomes after doing these role plays, especially kids and mothers' interaction and helping relationship. So this was one of the learning experiences we received from our participants, and by keeping the cultural consideration, it is one of the most relevant intervention to be implemented here in Pakistan. And we at the Pakistan Institute of Living and Learning are so excited to implement this program and expand this program across the country with the diverse group. So we, as a part of the training before implementation of this program, this is one of the mandatory session to be conducted as a pilot testing of this program. So we implemented this Strong Families program in Islamabad as well as Peshawar as part of the training before the actual implementation of our training with the parent and the child. So you can see some of the glimpse of the activities that we conducted in Islamabad as well as in Peshawar. And again, the next slide, please. The feedback from the participant we received after conducting this program in Islamabad and Peshawar was, they mentioned that the training material was very clear and practically relevant to the context, especially in Pakistan. They have a diverse culture. Balochistan, Gilgit-Baltistan, in ICT, Islamabad, as well as the Punjab, we have a diverse structure. So this is the beauty of this program. It is very culturally relevant, which is very, very relevant to the cultural context of the diverse cultures and backgrounds here in Pakistan. And the few of the participants also reported they after doing this kind of the role plays and exercises with their kids, they really improved the relationship between the child and the parents' relationship that otherwise they had lots of difficulties in interacting with their kids. And they also emphasized and they requested us to implement this program and expand this program in different communities. So this was one of the first phase of our implementation program of Strong Families in Pakistan. And because we have to culturally adopt this Strong Family program in part of the country, especially Gilgit-Baltistan, which is one of the remotely area of Pakistan, which is the unprivileged, underserved area of Pakistan in Gilgit-Baltistan. And we have because the cultural background of the Gilgit-Baltistan, if I say, is the low resource and a challenge setting in Pakistan, where education ratio, especially in Hunza, is 100%. But unfortunately, we don't have the health access and other opportunities and resources available. That's why the children and the other kids are moving to other high cities for the healthcare facilities, education, and other things. So we have the harsh geographic and climate conditions, especially weather, which falls almost minus 31, 33 degrees Celsius in winter season, especially in December and January. And you cannot live in Gilgit-Baltistan, especially in Hunza, if you have any plans to visit to Hunza.
I think we might have lost Dr. Salman. Rabia, is there a glitch with Dr. Salman's connection?
Yes, the internet connectivity issue.
Probably he'll reconnect.
Yes.
Do you want to check with him, Rabia, on WhatsApp?
Yes, I'm checking.
Yeah.
I guess we should not be amazed that there's glitches in the technology. We should probably be amazed that so much works, that we can get together from so many different countries and so many different people, and it works so well. So we'll have to be just a little bit patient on the periodic glitches. Thanks for your patience on this. Naseem, if it continues for some time, do you want to go to the next one?
I think we'll do that. And then when Salman comes back, we can carry on from here. So
Yeah.
let's see if Rabia has gotten anything from him through the WhatsApp. Otherwise, we can move on to our next speaker, because luckily we've got both our speakers. Rabia, we'll move on to our next speaker. Dr. Salman can join us later.
Yes.
Is that okay?
Yes.
Yeah.
Yes, that's
Okay. Okay, so yeah, that's better. So our next speaker is someone that I always do this to her, that when I'm introducing.
Is this me? I just need to know, get myself
No,
ready.
Lynn, you are
No.
after her.
Oh, thank goodness for that.
Yeah, you're next, Lynn.
Yeah. So it's Mina Hussain, and I feel so proud to introduce her, because I've seen Mina grow as a child, as a medical student, as a trainee psychiatrist. And then when I now say, I'm introducing Dr. Mina Hussain, assistant professor, it's a very good feeling. So in adult psychiatry and health systems, she's at the University of Toronto. She's a clinician teacher at Center for Addiction and Mental Health. Alongside her clinical work, she has a wide-ranging involvement in academia, teaching, and creative arts. She has utilized the creative arts as a tool for public engagement, raising awareness, and addressing stigma. She has produced award-winning short films, which have been officially selected at several international film festivals, public engagement, and academia events. Welcome, Mina. Over to you.
She's yeah, not able to unmute, Dr. Mina.
Oh, mic's
Lata, can
not
you please
working.
check?
It is. Oh, it did for a bit.
Yes, now.
Mic is not working.
No, you have stopped your mic again. Yes, now you can talk. It's just on and off.
Today is our glitch day.
She's getting someone to help.
Yeah, let's get sorted.
I'm pleased I recognize that Dr. Nancy Cohen is with us today. I'm so glad Nancy, Dr. Cohen has been Learning Through Play supported director of research and evaluation for decades, and has been a strong supporter and continues to be that. And we're delighted to have her as as a participant today in this series.
Andrew, it seems somehow it's going to be Lynn.
Yeah. So Lynn, here's Mina. Let's see whether Mina. Just 1 second.
Yeah.
So we'll give it another moment, I think, Naseem,
Yeah.
and just ask whether Lynn would just mentally.
I'm
Yes.
around. I'm just waiting for you to tell me what you want me to
Okay.
do.
Oh, thank you,
Okay.
Lynn. Minna, can you hear us though? You can hear us?
Yes.
Is it getting sorted or should we go with Lynn? Lynn?
It's like a mystery show here to see.
Minna, we'll start with Lynn and then
Okay.
it's you
All
and
right. Let's take a moment to get Lynn set up here. And while she's doing that, I want to introduce her.
I've got screen sharing, have I?
I'll let Rabia work on that to make sure that that's.
I hope I'm screen sharing. Yes, it
Yes, you
says
are.
I am. Great.
So let me introduce Lynn. Lynn is one of my favorite people in the world, folks. You got to know that. And to start off here, and if this was a baseball game, then the presenters today are all on base. And what we've got Lynn here, she's going to hit a grand slam and bring everyone in. That's just the way Lynn is. She just has a view of the world from a perspective of no one else I've ever met. She goes where it's most difficult in the world. She writes about it. She observes. She writes about it. She and her husband just are not afraid of any of the disasters that happen in the world. And I have just no end of regard for her. And Lynn, I'm so glad you're with us again. This is your third time presenting in this international conference here. And so let me just say a few things about Lynn, something I learned I didn't know before. But anyway, I know that she's a psychiatrist. She's a child and adolescent psychiatrist, writer, and relief worker. She's been engaged in assessing mental health needs and establishing and running mental health services in disaster, conflict, and post-conflict settings around the world since 1990. Most recently, she has been developing interventions to improve maternal and child mental and physical well-being in adverse environments, including Ethiopia, Venezuela, Guatemala, and Bosnia. Until August 2011, she was the Senior Technical Advisor in Mental Health for International Medical Corps. She's a course director for the Program of Mental Health in Complex Emergencies at the International Institute for Humanitarian Affairs, Fordham University, and consult to the World Health Organization, UNICEF, and UNHCR. Her most recent book is, and listen to this title, it's a long one, Sorry for the Inconvenience, but This is an Emergency, the Nonviolent Struggle for Our Planet's Future. She has a PhD in social psychology and political science. And this is something I didn't know, the next one. In 2001, she was made an officer of the British Empire for her mental health work in conflict-affected areas of Central Europe. Lynn, it's a delight to have you here, and take it away.
Okay, thank you so much for the introduction. I hope you can all see my slide clearly and not my notes.
Yes.
So, the emergency that I've been dealing with really for the last 5 years, I mean, 5 years ago, pre-COVID, we were in Belize, which my husband and I were working with a small charity there, and we came home and we were going back to Belize, but COVID stopped us doing that. And actually, I started writing the book that Andy's just mentioned, because the emergency that seemed to me underpinning all the emergencies, conflict or not related, was the climate and ecological crisis. And I felt that in living in a first world country, we had a major responsibility to address that. Now, it didn't stop me doing these trips that Andrew has mentioned and continuing on the program. But what Rabia and all of you have been asked me to do is actually to talk about this emergency, because I want to find a way, and I'm very glad to have questions and feedback from you guys, how to integrate education on this emergency into the educational program that we do with mothers and babies that I've discussed in the previous 2 conferences. This is a picture of me working in northern Ethiopia in 2022. And we all know that the first 1,000 days is really important for later life, which is why UNICEF has got this very nice, what they call the nurturing care framework, as the diagram shows you. And we know that we need to protect all those aspects, protect mother and child health. But I really am worried about the greatest threat facing them now being the climate and ecological emergencies. So what I'm going to do in the next 20 minutes, and forgive me if this is sort of teaching, what do you have there? My grandmother to suck eggs. But you know all this stuff. I am going to spend some minutes on what this emergency is. And then I'm going to go through the direct effects on both the developing brain of the infant and the mental health of the mother. Now, each point that I make is a whole lecture in itself. And I'm focusing on mental health. I will mention physical health effect because it's another whole lecture to do the physical health effects. But if I flag some key points that might excite you, and I can always come back and say more next year. So let's press on. And somebody give me a 5-minute warning. Okay, sorry to be boring, but this is an emergency. And this graph is really well worth, feel free to steal it and share it because it does show you how global average temperatures have risen with carbon dioxide. And we start off seeing, first bit of the graph, that it's all flat. It's wonderful, 2,000 years and stable. And we had an enjoyable, predictable seasons and weather. But then the industrial age began and we discovered we could burn fossil fuels, which has really powered our civilization, as we call it, as we know it, and we continue to burn them. And they release enormous amounts of carbon dioxide into the air. So we have the hockey stick that you're all familiar with. And the red line is CO2 and the blue line is temperature rise, which goes up absolutely with it. This is not a matter of debate or discussion. It's a matter of physics. I'm sure there are no climate deniers in this audience, so I don't have to say that. This May 2024, carbon dioxide parts per million in the atmosphere were 428. Safe levels are about 350. I don't know what we're doing. I love the fact that Arnold Schwarzenegger calls it a pollutant. And levels of carbon dioxide are the highest they have been for 23 million years. The last time they were this high, trees were growing in Antarctica. There were no human beings around. And I find that slightly worrying, really. So more graphs, but it's worth looking at the temperatures for the last 200 years to show you that global warming is not something that's going to happen in the future. It's happening now. And by the way, it's very interesting. Some of you are in Canada. Europe and northern parts are warming at twice the global average rate, which is very interesting. So we're hitting temperatures way above the Paris Agreement. That's not global average, but it is really worrying. And I thought I'd just one more scientific looking graph. This shows you how far beyond the norm we are. The last 11 months have been the hottest on record. Look at the lines for 2023 and 24. The planet is headed for 2.5 degrees of heating, which will have disastrous results for humanity. A recent poll by the Guardian newspaper in the UK of leading climate scientists, 400 of them replied, and they don't think we're going to stay below 1.5 degrees. I probably don't have to remind many of you as to what that actually means, but just let's spell it out. Heat waves across Europe in the summer of 22, we don't have the figures for 23 yet, caused at least 61,000 extra deaths, which is why Antonio Guterres has already said we're in the era of global boiling. In 2023, wildfires burned an area the size of Greece in Canada and sent smoke pollution as far as New York and Florida. Wildfires, I know, have started again in Canada in the last few weeks. Floods in Libya, who remembers what happened in Libya, killed 4,000 people at least, 8,000 disappeared, probably many more. These days, the Department of Education in Manila has ordered 47,000 public schools to switch to home-based learning because the heat is too great for children to come to school. 30 people, and I think that's an underestimate, have died of heat in the last few weeks in Thailand. Floods in Somalia and Kenya are devastating lives as we talk. climate change is not a future threat, it's a current reality. I just thought I'd share with you a website that I use for my work called Relief Web. What's interesting to me is that since the last couple of months, 3 or 4 months, they've started posting WMO, World Meteorological Organization reports on their disasters page. They didn't used to do that. And when you look down through the list of current disasters, it's weather related. I've just put April up there for your interest. All the news you don't get in the news. Sorry, I'm having trouble advancing my slides. I don't know why. Let me put this out of the way. Is it advanced? Yes, that's advancing. The fact is, I started this work, as Andrew said, I feel terribly old, 30 years ago. And 20 years ago, I was working with refugees fleeing a genocidal war in Darfur, which I'm sorry to say is still continuing. And what I didn't understand then, but I do now, is the degree to which climate had played a role then in that crisis. Because actually it was about drought and devastation, and then the quarrel that arises over resources. So it was an exacerbating factor, which the government at the time used to foment a genocidal war, which is, as I said, continuing. Now, my job was to establish mental health services, and Tabitha, who allowed me to take her picture, and it's not her real name, showed me what hunger means for a mother and child. She was brought to me, psychiatrist, because she was depressed and confused. She'd actually abandoned her baby because she thought he was dying. This was again because through hunger and lack of stimulation, the baby was more or less unresponsive. So we took both of them to the therapeutic feeding center. And one of the things I noticed there, and I think I've talked about this with you in previous talks, forgive me if I have, but I'll say it again. It was where I really learned to do early child development programs, because in those centers, even though mothers were getting food, they didn't look at, they didn't cuddle, they didn't play with their children. They just completely lacked that warm, responsive, stimulating response that's essential for her early brain development. Sorry, it's unintentional. And what Tabitha and her baby showed me is that it's the indirects of climate, drought, conflict, and war that play out to harm the health of the mother and child through malnutrition and the subsequent psychological effects. So I decided then that I wanted to work on this, and actually I was starting to work on the climate then. So what's happened is my husband and I, we talked about it last year, we had developed a 10-session program that addressed mother and baby's physical and mental health. And we did it in these different countries, and we like it, and mothers and babies seem to like it. But I realized this year that it was missing some essential stuff that we've got to do. We've got to find a way, and I'm just talking to you about the very beginnings of the project, we've got to find a way to talk to mothers and babies, talk to mothers, parents, fathers if they come, about these climate threats and how, first of all, do they understand them, what they mean, and how can we address them. So I'm going to go through with you, share with you some of the research I've been doing, because what's interesting is when a lot of people in the networks I'm working were talking about climate threats, but guess who gets left out? Mothers post-reproductive age and babies and infants under 5. And yet there is a lot of work around on this, and I'm pulling some of it together for myself. I'm not a researcher, I'm pulling together other people's research, because I want to find a way to communicate this in a non-terrifying, helpful way in the trainings that we're doing. I really recommend a working paper by the Center for Developing Child, came out a little while ago, on heat. So by heat waves, by the way, we mean average temperatures above 10% of the top temperatures the last 3 days, or 2 degrees of the high heat waves. And by the way, 23% of children are currently exposed to high heat waves. That's about 500 million children, and that's expected to rise to 2 billion by 2050. But let's start with mum and the effects of heat on her, okay? Adverse pregnancy outcomes, obviously profound effect on the developing brain. And after birth, the dehydrated, unwell, overheated mum is going to be stressed and anxious and less able to give her baby the protection and attention she needs. And she needs to do that because the baby themselves is one of the most vulnerable creatures to heat. And this is because they've got a very large surface area compared to their mass. They heat up more quickly. They have much less capacity to deal with the heat, to release it via sweating. They can't crawl off and get water and shade. There's multiple organ failure, possibly, and even mild overheating activates the stress system, which disrupts sleep, which both have long-term effects. I really recommend the paper that the Center for Developing Child have written on this, because I think we should all really understand this stuff. Moving on, of course, one way to address this heat is access to water, which unfortunately is generally in very short supply in these places. And I think this slide speaks for itself. The facts come from UNICEF. Many of the countries I've witnessed have children under 5. They're the ones that are sent for water. I've seen 3-year-olds carrying water carriers on their head with all the attendant risks of doing so, including, of course, more heat exposure, abuse, and missing out on education. And then, after drought, storms and floods, excuse me, water in the form of excessive precipitation, cyclones, hurricanes, underpinning all the extreme weather events that we're witnessing today. The physical effects are obvious and dramatic. The mental ones are not so visible, but they are enduring and profound. For example, interesting study, after a major storm in France, 94% of children aged 0 to 5 presented at least one manifestation of acute stress, and about 1/3 showed developmental regression. But arguably, it's the impact on the carers through their absence because they've died or been lost, or their changed mental state and their behavior. In every disaster where I've worked, dealing with the mental impacts of loss, of loved ones, of stress has been my major focus. And stressed and depressed mothers can become very harsh and neglectful parents, even though they don't want to be. And then, of course, the loss of infrastructure compounds those effects. You don't have the health centers, you don't have the schools, you don't have the support, you're probably displaced. I think many of you who live in Pakistan, work in Pakistan, you know all of this from the terrible floods from a couple of years ago. And then, of course, and this gets left out as well, vector-borne diseases. Actually, I had a personal note here. You know, my friends, when I arrived in Norway, when I'm trying to have a holiday, said, oh yeah, we're now getting far more ticks than we used to in certain places, and we're carefully tucking in our trousers and examining ourselves for ticks when we get home. Ticks are serious. So are mosquitoes. And you're seeing vector-borne diseases in places that never have them. I've put them up here. Those plastic bottles that lie around in every camp I've worked in, they're ideal containers for stagnant water. All this alters the distribution. We're now seeing dengue, malaria, Zika, and diseases they've never been before. And as I put on the slide, these diseases are associated both with consequences for the pregnant woman, with increased odds for maternal mortality, stillbirth, neonatal deaths. Newborns with chikungunya can get it from the mum, and then they develop fevers, peripheral edemas, neurological diseases, hemorrhagic symptoms, myocardial disease. It's serious stuff. And pregnant women, this has got more news a few years ago, who become infected with Zika have higher chances of microcephaly. And note that pregnant women and children who live in areas with limited access to tap water are even more vulnerable because they store water in these big still vats, which are absolutely ideal breeding ground for all these mosquitoes. So as I said, every topic that I'm bringing up, heat, water, vectors, is a lecture in itself. And please forgive me for speeding through them and highlighting the main thing. And I'm going to come to one of the most devastating, and it's invisible. You know, actually, sometimes I say when I'm doing just lectures on climate change, I say to the audience, would you put the exhaust pipe from your car, if you're still driving a gas car, in through your window? And everybody goes, are you balmy? Of course not. You know, that's in movies, that's where committing suicide. Yeah, we are pumping our exhaust, our toxic pollutants into the atmosphere, where it doesn't just go off into space and disappear. It stays around. And 98% of Europeans live with toxic levels of air pollution. It's killing more people, according to this study, than dirty water, AIDS, malaria, or indeed war, because it aggravates so many other diseases. 253,000 deaths could be attributed to fine particulate matter in 2021 because people were living above the WHO recommendations. I will go on a bit. What is it? I've listed a few of these here. And of course, you think of all the people who burn wood and fires in their homes or to cook because they don't have anything else. We forget about methane. It's toxic. We forget about ozone. And here's another interesting statistic. 99, according to WHO, 99% of the global population breathe polluted air, which means for mothers and babies, these are the risks that I'm listing for you. I don't want to spend time reading them out, but basically you're talking as usual about low birth weight, preterm birth, you're talking about allergies and asthma with the neurological development effects, low intelligence, poor memory, long-term risk of increased mental disorders. Actually, a very interesting work, big change from my childhood, is people are now saying that perhaps schizophrenia with its high prevalence in urban areas has something to do with air pollution. Not something I learned when I was training as a psychiatrist. And then there are the specific pollutants. I remember my mother banning iced lollies when I was a small child. Why? Because they came in lead molds. So I wasn't allowed to eat them. And then I was allowed to eat them because the lead molds are gone. We got rid of lead pipes. But lead is still around. And it's a pollutant. It's in the wallpaper, it's in the water, and it's serious stuff.
About 5 minutes, then.
Oh, thank you very much. I'm going to skip on. Okay, this is a very nice paper. I just wanted to flag it for you that brings together everything I've said. Why I like it is that it brings together the social, the economic, and the effects I've taught with the impacts on the mother and child. Don't let's forget that the more adverse the environment in which the mother lives, the more poor she is, the more her socioeconomic circumstances are, the more exposed she is to all these risks I've mentioned. That's basically it. I'm not going to spend more time on this slide. Okay, and this is a really key slide because this is what the climate crisis does to that nurturing care framework. It increases the risks of diseases, it increases the risks of food insecurity, it disrupts education, it causes conflict, it causes exploitation and abuse, and then as a result of all that, you guess what you have? Toxic stress in the child. And I don't have to do a lecture here with this audience on what toxic stress and adverse child events, those are all adverse child events, do both to the child in their childhood and with long-term effects into adulthood. ACEs, toxic stress, I prefer those terms to trauma, are not jokes. And the more stressed the caregivers are, the more neglectful they are, the more harsh they are as parents, which adds to the stress. So this is really serious stuff. I've put in some slides and I've only got 5 minutes, so I'd ask you to look at them at your leisure. But what this slide basically shows, the bad news is that even if we take the action that we want to take, children born today are going to have to deal with many more climate disasters, 24 times as many as any child born in my lifetime. We are making it worse. I want to work on this now with the mothers and babies I'm working with individuals and communities. So the first thing we're going to do in Guatemala, where we're going in the summer, we work with an indigenous NGO there who I'm glad to say are already working on this issue. They have been looking at ancient knowledge and how they protect themselves. We want to learn, what are they already doing? What do they know? And what risks do they need education on? How can we help them address those risks in their community? And how can we ensure, for example, in a heat wave, do pregnant women and children in that community have access to cool spaces and shade and hydration? Do they have good nutrition? Is the community engaged in this issue? So working on the individual and community level is something I would love to do. If anyone's doing it in this audience, please get in touch with me. I'd love to discuss it. Unfortunately, individual interventions are not enough. This is a joke from Australia, but we've got to do something about the people cutting down the trees. I'm glad to say that UNICEF is really working on this. They produced an excellent report for COP28. Is it being followed? No, but we have to push. We have to push as professionals that we've got to cut emissions by 2030 because 2050 is too late. How do we do this? And if we do it, it's not hopeless. This slide shows what the effect of doing it could have. If we cut, the example on the impact on heat waves could be cut by 45% if we can just keep temperatures below 1.5. It can be done. I've given a couple of ideas. This is my last 2 slides, Andrew. A couple of ideas here. One is, why can't we treat the climate and ecological crisis as a planetary emergency? The World Health Assembly is coming up at the end of the month on the 27th of May. It is not too late to sign this petition. 200 medical journals talked about it last November. I've put the link on the slide. This is to say WHO declare a global health emergency around the climate and ecological crisis because it's going to take far more lives than COVID. It's already taking those lives. It is a health emergency. And then you can also look in your own lives, as Desmond Tutu recommended. We use the strategies that we use to fight apartheid. We can fight the climate crisis. They're called divestment. All you have to do is look where your money and your university's money and your business's money and your practice's money goes and ask them to move it to somewhere that doesn't invest in fossil fuels. I'll stop there. I'm happy to answer any questions, both now or by email. Thank you very much for the time to spend on this.
Lynn, you've done it again. You take us in the difficult parts of the world and difficult ideas, and you are articulate. And thank you very, very much for the work that you and your husband do. And we look forward to continuing. My guess is that there's quite a number of people that are going to want your presentation, so I'm hoping that they can.
It's available. Just to say, Rabia, I slightly changed some things, so I'll send you my newest version. Okay.
Thank you for that. Okay, Naseem, we have about 30 minutes, and you can decide you're going to go back to earlier speakers.
So I don't think we've got Dr. Salman with us back as yet. So Minna is with us. And so over to you, Minna. We can't hear you still.
One suggestion is to take your earbuds out of your computer just to see whether that would work. I don't know whether it will or not, but it does. That does it for me.
Me?
Yes.
Can you?
Yeah.
Yes.
Yes, we can hear you.
Okay. Thank goodness. It's I have been changing around this computer for a little while. Okay. I'm ready to make a start. Rabia, should I just share my screen?
Yes, thank you.
Okay. Are you able to see this?
Yes, we can.
Yeah.
Okay. Okay. So firstly, apologies about those tech issues. And secondly, thank you for having me here. And for that very warm introduction, Professor Naseem. Professor Naseem's been my mentor throughout my career. So it's really a pleasure to be here. So a little bit by way of background, I am a inpatient psychiatrist. Clinically, I work at the Center for Addiction and Mental Health here in Toronto, Canada. My research interest is generally around women's health and parenting. I am extremely interested in research, translation, knowledge translation, which is something that has been talked about in previous sessions about basically utilizing what we know and translating it so that it's readily available for the public. So I'm involved in the creative arts, I produce short films, and I'm extremely passionate about raising awareness about mental health and having the public engaged in the interventions that are available already. So as I was saying, my day job is I work predominantly in inpatient psychiatry. I also spend a lot of time working in other acute sectors. So I spend some time working in the emergency department, still here at CAMH, and a crisis walk-in clinic. So what I want to talk about today is a really important topic. It's parents who are across these settings. So mainly in an inpatient setting. So I'll talk a little bit about some of my own experiences. So some of the cases that I've come across and some of the conversations that I've had with my colleagues, various different members of the MDT, and then move on to talk about some of the perspectives from research and then about some next steps. So this is a very simplified versions of some of the scenarios that we come across here in the hospital. And I'll just briefly, these are all fictionalized, but generally I'll give you an idea of some of the things that we come across. And some of the issues and the conversations that have come out of these scenarios. So I'll start off by talking about this image on the left. As I was saying, I work across a few different settings, and when I was working in my crisis clinic, I came across a woman, a 44-year-old woman who had been seen by various different doctors, social workers, therapists by the time that she got to me. She'd been initially seen in the emergency department and then was referred to our walk-in crisis clinic. By the time she got to me, she had been seen by 3 or 4 different doctors, by social workers, and she also has a therapist that she sees on a weekly basis, who she had been seeing for around 6 months. So she has a diagnosis of borderline personality disorder, and she's a single parent to a 4-year-old girl. By the time she got to me, when she was it was our appointment, she was in crisis. So basically what had happened was that she had disclosed to her therapist that there was an incident where she felt extremely frustrated and became extremely emotionally dysregulated when she saw several pigeons on her balcony. And she began to shout at the pigeons. And her 4-year-old daughter was able to see this through the window. So the therapist had decided that it was important for her to call the CAS, which is the Children's Aid Service, and felt that they should be involved in this patient's care. By the time she got to me, she was very distressed about the situation. She felt betrayed by her therapist. She actually stopped seeing her therapist at that time, and it got to a point where, due to her levels of distress, we were actually talking about perhaps an inpatient admission would be helpful for this person. So this brought about a lot of questions. We had a case meeting about it, about the Children's Aid Services, what their role is. And what was clear was that there was a very big discrepancy between different clinicians and what their threshold is for getting these services involved. What also came out of it was that the CAS is going through a period of rebranding at the moment, but the person had expressed that they found the whole process extremely punitive and felt worries that their child may be taken away from them. So that brought about a lot of various different issues, including what would happen if the person was admitted to hospital. Another case, just briefly touching on that, was a man who had experienced a drug-induced psychosis. So he had spent some time on our intensive care unit, meaning that he was very agitated, a very high level of mental disturbance, and eventually he was brought to the general unit once he was treated and once his symptoms started to resolve. He does have a 6-year-old daughter. The daughter lives with the mother. And they're separated, but he's very close to his daughter. He sees his daughter a few times a week. And the question came into whether we should be facilitating a visit for him to be united with his daughter. Daughter did have a lot of questions, and that brought in a lot of questions within the team, talking about the facilities that are available, which I'll talk about later on. So just about inpatients who are parents of dependent children, there's a variable prevalence, but it says around 20 to 45% of the inpatients have dependent children. So that's a large range, but also a large number. And it's in the UK, I don't actually have numbers from Canada, but in the UK, they say that there's around over 16,000 inpatients, and around 45% of them are parents of dependent children. We know that majority of inpatients have severe mental illnesses, so things like bipolar disorder, schizophrenia, severe depression, and they get to a point of crisis, which is why they're admitted to hospital. Parenting, we've discussed this at length, but is a very challenging, enormously challenging for healthy individuals. If you add on a severe mental illness onto that, the layer of complexity just increases. We know that there are adverse outcomes for children, which I'm not going to go into a huge amount of detail in, but we know that these children can end up having behavioral difficulties, lower academic success, vocational difficulties, and are more vulnerable to developing themselves mental illnesses and physical health illnesses as well. So hospitalization has been identified as one of the most difficult times for both parents and children. If you think about it, that's, for a lot of people, they're not actually separated from their parents, and sometimes to be forcibly separated, for parents to be forcibly separated from their children can be an extremely traumatic experience for them. So there's actually very little, these are conversations that I've had with my colleagues a lot, and in my unit, definitely, there's no specific interventions that we do use for this patient group. So even if they exist, they're not widely used, and I've worked across various different inpatient settings. So just to talk, what I've been interested in has been what the perspectives are of the parents, the carers, and the children who experiences. I'm also interested in what the perspectives are of the clinicians providing care, but I'll talk about these three perspectives now. So I've looked through the literature, and I've kind of merged them to talk a little bit about some of the experiences and tease out some of the themes that have come out of these. So first of all, these are also conversations that we have on our unit a lot, which is coming up with the decision about children visiting an inpatient unit. So it's a very nuanced decision. It's not a simple answer. There's a lot of safety issues that come with bringing children onto the unit. There's not a huge amount of guidelines, and often it's thought of is this something that's going to cause more harm than good? So just going back into some of the perspectives, some of the themes that have come out of this are, we'll look at the parents' perspectives first, is worries about who is looking after the child. Parents, their children are the most important, to majority of parents, the most important things in their lives. It can bring about a sense of purpose. Obviously, they have this love for their child, and there's concerns about what's happening to that child when they're in hospital. There's worries about maintaining connection from hospital. As we said, there's difficulties in facilitating meetings. They're worried about what's going to happen at the end of discharge, once they are discharged and sent home, and about what the child is actually experiencing. And I put some quotes over here that I just felt were quite powerful. When I was admitted to hospital, I was thinking about my children. Where are they? Who is taking care of them? I was scared when admitted that they would take my children away from me. That's a lot of my clients. Sometimes what they talk about is the worry about getting social services involved, and having the worry, especially when they're going through things like custody battles, having the child taken away from them. And then post-discharge planning as well. Sometimes people stay in hospital for a long time. So on my unit, the average length of stay is around 2 to 3 weeks. Sometimes after that, patients are moved to other units where they end up on sometimes in hospital for several months, at times rarely, but at times several years. And this is a quote with somebody that says they've been in hospital for a long time and they've forgotten how to be with their children. So let's look at carers' perspectives now. What carers have worried about is that they felt lost in this process. So carers are people who, for example, aunts, uncles, grandparents, the other parent, or a friend, a guardian who's looking after the child. And what they felt is that there's no guidance on how the child should be managed. How do you tell? It's a complex situation. How do you tell a child about their parent's condition, and how do you prepare the child for their visit? So that was a lot of what came out of it, was just a lack of control and feeling lost in this process. And what I was particularly interested in was the child's perspective. And these studies generally looked at the qualitative studies looked at the children's views who were aged 8 to 15. And it was interesting what was coming out. Fear was a big theme of this. Children felt scared. This was a quote where somebody felt scared, but knew that their dad wouldn't let anything happen to them. There was a lot that came out in terms of the facilities, that there's not a huge amount of child-friendly places that they could come to. They felt very constrained, stuck in a room with nothing to do. It can feel like an extremely restrictive environment, like often, which we have to do for safety, is, check everybody, remove certain items from them. And they also found the hellos and the goodbyes very difficult with their parents. So leading up to the greeting, they often haven't seen their parents for a long time. And then having seen them, but then having to go away was identified as a very difficult time. So I did look into what interventions are tailored to this group. There's not a huge amount. There's been some studies that have shown co-admission has been helpful. These are just not practical in every setting. For example, in the setting that I work in, where patients can be very highly agitated and disturbed, it just wouldn't at all be feasible to have a parent and a child admitted them onto the same unit. But in some less acute settings, that has been shown to be useful. There has been a few more interventions that have looked at post-discharge. But again, most of these were looking at preventing the parent from being readmitted, which is extremely important, but not a huge amount was looking at how to support the parent with their parenting after they've had lengthy admissions. So what are some of the barriers? I've talked about this before, but again, there seems to be very limited guidance, especially about what's available for both staff and for parents and children, carers. Within my own team, this is something that's really talked about. There's different standards of practices. At times, people have policies where they limit children coming onto the unit altogether. Obviously, safety issues have come up as a huge barrier to implement any interventions, any visits. We do have to be pragmatic about it. It is paramount that we keep ourselves safe, that we keep patients safe, and of course, that we make sure that the safety of the child is maintained. So, and finally, stigma had come up as a big barrier to facilitating this. In my own experience and reading the literature, patients have felt a sense of shame. They felt a huge sense of self-stigma. Carers as well have felt that they didn't want their child to see their parent in this, when they're going through this certain period of their life. Parents themselves have reported feelings of inadequacy, feelings of embarrassment as well. So what can we do? I'm a big believer in the use of technology. I think it's a very underutilized tool. Majority of the patients that are on my unit have smartphones. We also have iPhones that are being passed around where patients can play games, and this could be a really good opportunity to maintain the link between a parent and a child, especially when we're going through periods of prolonged admissions. Stigma was something that came up, and as I was saying before, I feel very passionately about knowledge translation and knowledge dissemination. What has come out very clearly was that everybody felt that that there's not a huge amount of information over here that's easy to read. So what our team is working on at the moment is we're working on developing information for parents and for families about this, what it means to have, for here at CAMH, what it means to have be admitted to hospital, what that looks like, and use the psychoeducation and make it specific for certain age ranges as well. So as I was saying before, I produce short films, and this is the next one that we're going to be working on. It's going to be an educational tool for families to be able to explain, tailored towards children, and to be able to explain what their parent is going through and what this experience is going to look like for them as children. So collaborative partnerships are extremely important. So for example, with the CAS, in my practice, there's been a handful of times that I've actually called the Children's Aid Services. I think there needs to be more collaboration between inpatient units, emergency departments, and the CAS. Also partnerships with schools, with after-school clubs, religious institutions, so that we can make people more aware of this. And of course, continued research and innovation in this area so that we can come up with more effective and innovative interventions for this patient group. Thank you.
Thank you, Mina. Brilliant presentation, very clear, and what an important topic. But really, in practice, even while working in the UK, not something that we often think about.
Yeah.
So hugely important. Good luck with this work, and keep us posted. So what we are doing is we'll just check if Dr. Salman is joining again. If he's not able to join, we've got 10 minutes. So Andrew, if it's okay with everybody, if he's not joining, I would propose that we have 5-6 minutes for questions, because I'll only need 1 or 2 minutes to thank everybody.
That's just fine. Yes, go ahead.
So Rabia, is Dr. Salman there? Would he be able to finish? Because he was,
he can speak through like just my phone speaker. He's not able to join online. So if that's okay, so we can check. Otherwise, we can move to end the session.
Yeah, let's do
Should
that.
we
Yeah, bring him on by phone.
Yeah.
Sure.
Could you show us the slides? Take us through the slides as he's speaking. Yeah.
He's just trying to speak. If you can just acknowledge, if you can listen to him, Dr. Salman.
Yes, ma'am. I can. Can you hear me now, ma'am?
Can you hear Dr. Salman?
Yeah, it's sort of echoey, but let him try to see how it goes. Go ahead.
Can you please speak a bit louder?
Okay. Can you hear me now?
Is he clear now?
No, I don't think, no.
Yeah, it's certainly not echoey, but we can't hear him at all. So,
too far.
Dr. Salman, we are not able to listen to you.
Can you hear me now?
Hello?
No.
Hello?
Yes, we can hear you now.
Thank you so much. So again,
Dr. Singh, can you hear?
Can you hear me now?
No.
I don't think that technology is working.
It's
Sorry
not
about
going
that.
to work. But thank you, Dr. Salman, for giving it a go. we've got a couple of minutes, 5 minutes. We can open it to the forum if people have any questions for any of our speakers.
Well, yeah, I haven't made any charges. Sorry? No, not for those amounts.
So maybe Jill, if I can just very quickly ask or make a comment. I mean, I really liked the listening because especially in our context, if it's anything like counseling or therapy, then the stigma comes in. Listening is much more acceptable because we are currently working with Dame Tina Lavender on a bereavement for parents who've either had a stillbirth or neonatal death. And we are using this, it's just a feasibility, peer support.
Yeah,
And
lovely.
it's really going well. In fact, when the sessions are over, mums want to continue with the peer supporters. So I wonder, is that something that can be?
I mean, I must say I'm a massive fan of peer support. I've done lots of studies with infant feeding, neonatal care, trauma. In fact, we're just doing a review looking at peer support with women who've got trauma histories. I think it's one. I think that the listening or birth reflections is really important to help them work out the narrative. You know, the missing pieces. But getting support in that, you know, from those who understand with the shared background is just so important. Like, for instance, we looked at psychoeducation groups. So you had the facilitators telling them about, you know, birth trauma and trauma symptoms and responses and gave them tools to manage. But one of the most important things that they reported was that connection with others in the group. So I think that's like a wonderful thing. It could be an add-on that they have that opportunity to review the notes, ask the questions, get the missing pieces, and then be with their peers. So yeah, I think that's a wonderful idea.
Thank you. Usman?
Yeah, I want to say something about the climate change. So I think that's a very huge area for Pakistan also. We are trying to work on that. Dr. Fiza recently worked on something, and we are trying to build that area also. Flooding happens every year. A lot of people suffers in Pakistan. Then, so if I think all Pakistanis can agree, our weather system has totally changed now.
Oh, we've lost Usman. I'm not sure whether Usman has finished or we've just lost him. Dr. Anila, it's not. Yeah, now we can hear.
It was so I'm saying that it is really important for us, and I'm hoping we can work together also, inshallah, in future.
Fantastic. Dr. Anila?
Yeah, just to reflect back the kind of like discussion we had about environmental issues. As I'm supervising some PhD related studies on relevant topic, I just want to share that we are looking at how our physical infrastructure, our home environment is actually helping us to deal with harsh and cold weather. Because in most part of country, we are facing harsh weather, plus the kind of like infrastructure we do have, it's not supportive at all, unless we have a lot of resources with us to maintain a home temperature. I mean, if we do have resources, we can afford air conditioners and then heating system. And those who do not have access to these resources, life is just like hell for them, especially during extreme weather. So we are trying to see how such kind of like environmental factors, they can act as etiological factors in diagnosis of depression, anxiety, and in certain cases, suicide as well. So this was just a sort of sharing the kind of work we are doing these days.
Thank you. And could I just flag that air conditioners are part of the problem, not a solution, and another example of how rich people, in fact, pollute the environment of poor people around them, because while an air conditioner cools your inside living room, you pour contaminated hot air into the outside environment and heat it up. So air conditioners are not a solution. They're a very good example of how first world and rich people in poor countries are adding to the damage. We have to come up with we have to cool in other ways. And how we give that advice directly to impoverished parents is really important. I'm all for government action, we've got to have that. But we've also got to help people. If you're in Thailand right now, you want to know how to protect your baby right now from heat. You need to know that.
Exactly. So see how much it's important to go for an awareness campaign, because there are a lot of things which most of people, they're not aware about.
Absolutely. That it's lethal.
Can I make a point here? This is Amber here. And in olden days, they used to make those blinds made of bamboo, and they used to throw water on it. So when the breeze used to come in, it used to cool the place. So I think we should go to our roots.
Absolutely. My friends in Guatemala are trying to use indigenous knowledge of their grandparents, and we need that globally. We need people to be sharing these kind of solutions. Thank you.
There was one solution also in India. There is a startup. They have tried to build clay pots and place it on the. Somehow they have tried to do that, and it has cooled down the temperatures for few degrees for the buildings also. So that was very interesting for me when I looked at it also. But that also comes from previous knowledge.
We've got Dr. Najma, last question, and then we'll have to end.
Thank you, Dr. Naseem. It was very interesting to know that all the people around the world are working for the betterment of the mental health. I was quite interested in the presentation by Dr. Salman. Unfortunately, it was not completed, but the strong family functioning and the strong family system, no doubt it is the main role played by the family, which is preventive for the betterment of the child mental health, and also for all the peoples across the family who are working in together in a connection of the emotional stability and the. Recently, I was working with the resilient aging construct, and I came to know that across the developmental phase of the child, it is inbuilt through the socialization, still from the start of the development, that how you are going to perceive the social phenomena, how you are inculcate modernization of the values and ethics, and how you are going to interact with the other persons across your society and across your family relationships. No doubt, we all have to work together for the sustainment of the societies. And here, the positive parenting, strengthening of the family functions is much more important as compared to the other tasks of the society. And I was very happy to be the part and as a listener of this program. And I congratulate you on the task, multiple wellness functions played by multiple psychiatrists across the globe. Happy to know.
Thank you, Dr. Najma. Thank you. So we've got to wind it up now. A big thank you to our wonderful, wonderful speakers, all of them, excellent presentations. Apologies for the little glitches we've had. Well, we've had some wonderful sessions, wonderful. A big thank you to all the participants. We went up to 56, 57 people joining us from across the globe today, Rabia. Is that right? Yes.
Yes.
And thank you to Andrew, who is really the backbone of our Global Parental Health Group and a Global Parental Mental Health and Child and Wellbeing conferences. So Andrew, thank you for chairing it. Thank you for leading this. Thank you for really, really supporting. So can we have a show of hands for Andrew?
You're very kind.
Thank you,
I
Rabia.
too want to thank you all, and I do want to thank the people who are providing the technical support. That so much went so well today. and I know it's a difficult task. Well
No,
done.
thank you. Yeah,
And,
absolutely.
So tomorrow, same time, we've got another wonderful lineup of people, and we'll look forward to you coming back if you can. And so we'll